Well, good afternoon, everyone. Welcome to this session on traumatic brain injury, a 4-hour session, one of the longest sessions of the conference, and we're going to cover all aspects, really, that I can think of related to traumatic brain injury, a really wide spectrum of talks coming up in the next 4 hours. My name's Michael Reid. I'm an intensive care physician and anaesthetist in Brisbane in Australia, and it's my pleasure to co-chair this session with Raymond Hellbuch from Linz in Austria. And we're going to keep to time. You'll see in your program that in every block of 3 talks, there is following that a 15-minute question session, but rather than do that, to keep I suppose people's minds focused, we're going to have questions at the end of each of the talks, but we're nonetheless going to keep to the schedule in those 3 talk blocks. So to start with, we have Dr. Deepak Kumar Gupta, who comes to us from New Delhi and India, to address the topic of traumatic brain injury and pregnancy. Deepak.
Thank you, respected chairperson and the august gathering. Well, I'm a neurosurgeon by profession, and it's such a proud honor and privilege for me to be here amongst intensivists and the physicians and to learn so much from you guys. Well, this is the hospital wherein I work. It was started by an act of parliament way back in 1956. It's All India Institute of Medical Sciences, New Delhi. And we have started now the trauma center in 2007, and this is 254-bedded dedicated trauma center. We got 37 neurotrauma beds, and we got approximately 25 plus faculty. In fact, there's an initiative by the government of India wherein our hospital, which is the hospital of the country, now the government has started 26 such hospitals in the country, so to improve the healthcare systems in our country. Now, regarding management of pregnancy with traumatic brain injury, we see less number of patients, but off and on, as neurosurgeons, we do come across such cases. And then it's like a shocker to the neurosurgeons, how to manage these cases. As of today, I believe we know that if we manage the mother well, the baby is managed well. This is the common understanding. And of course, mother is always the first priority by most of the physicians in the country. However, when you talk about whether to do a CT scan or not to do a CT scan, to do an MRI or not an MRI, to do an invasive pressure monitoring of the ICP or no ICP monitoring, there's so much of confusion. People do not have any guidelines as of now. In fact, if you look at the Brain Trauma Foundation guidelines as of now, the BTF 2016 and the consensus meetings of the CBIC group, there are no specific recommendations on guidelines about how to manage a pregnant patient with a traumatic brain injury. And time and again, we do come across patients who have brain death while they are being managed with a severe TBI. And then you are in a fix, how to manage such cases, whether to continue the somatic support or not to continue. And of course, when you talk to your gynecologists, your obstetricians, believe me, it's a total nightmare. When you speak to them, whether to do a cesarean section or not to do a cesarean section, they just try to protect or just to hold on and to continue with the pregnancy. How frequently the fetal monitoring, how the fetal monitoring has to be done, again, there's so much of incongruity. And how aggressive we should be. People do not talk about it. Let's say you have a baby who is 500 grams of weight and just 24 weeks of pregnancy. In a developing world, maybe you're not able to manage, but the same baby in a precious mother, if it is in a developed world, probably you're able to manage well. So which baby we should be very aggressive to continue or not to continue, people do not talk about it. Anti-seizure medications. Again, there's so much of confusion, which medicine to be given, and the timing of the drugs. People don't talk about it. What should be the timing of the anti-seizure medication to the mother? There is no discussion. Nobody is talking about lactation in the unconscious mother, because so many times we have these patients who are delivered and then they just land up with the engorged breast abscesses. So all these things are just not being discussed. I personally believe there is no head injury in the pregnant mother which should be called a minor traumatic brain injury. It's never ever a minor, because there have been enough data available in the literature now over thousands and thousands of cases where the outcome is considered shown to be bad, both for the fetus and for the mother, if there is a traumatic brain injury. Well, we do have this survey. I think it came up in the JAMA. Of course, the survey says that there was no association between traumatic brain injury and the maternal and the fetal outcome. However, it has to be read very carefully, because most of the evidence which comes from the limited, the low-level studies. So we just cannot reach to a conclusion that there was no association between the traumatic brain injury and the fetal outcomes. There is some association if you look at the cohort study. I think there were 4 in number in this study. Now, in case you want to improve the outcome of a pregnant mother or try to save 2 lives, I personally believe you have to understand the physiology very well. The hypotension in the mother will not manifest with the acidosis as commonly happens, because we know that there is a state of respiratory alkalosis in the pregnant woman. The hypotension, the hypovolemia does not manifest with the oliguria, because we know that there are changes taking place in the hypothalamic pituitary axis. And there are so many other things. The hypoxia is very commonly seen in the pregnant mother. Pregnancy per se increases the intracranial pressure. And we have to understand this. Even if a person sustains moderate traumatic brain injury, it is a state where the ICP is likely to be higher than the normal. So all these changes, they need to be understood very well by the physicians. Now, for the children, we very well understand those who are, I'm a pediatric neurosurgeon at my place, so we do understand that we have to position a child in a very distinct way because of the large head size. I think similarly, we need to understand the pregnant mother needs to be positioned also differently. The lateral decubitus or the lateral tilt by 30 degrees, nobody knows about it when you go to the emergency setups. They're just being nursed, and they have hypotension, and you just keep on pumping in the fluid. So these are the things which need to be known. Now, you need to monitor the mother and monitor the fetus. The mother can be monitored by the invasive or the non-invasive tools. Nowadays, we've got beautiful tools, the pupillometry, optic nerve sheath diameters, and they need to be utilized to the maximum. The problem comes when you talk about how to monitor a fetus. Believe me, maximum people, if you talk to a gynecologist and if they're not working in a center, they just don't come to look at the 4-hourly electronic fetal heart monitoring, which is being talked about in the literature very frequently. So the ground reality is very different from what we read and see in the books. There's so much of confusion as on today in the mind of the healthcare workers, whether to do a CT scan or not to do a CT scan, whether to put in a shield or not to put in a shield. There's enough data available now, and I think it's our moral responsibility to tell to the masses outside the CT scan, if indicated, is absolutely safe in a pregnant mother. On an average, you need around 2 to 3 CT scans in a mother for managing a case, which is fair enough. In fact, you can do up to 10 CT scans without harming the baby. The dose is approximately 0.05 rats, which is much, much below the expected risk. This is something I wanted to talk about. There is some experimental study has been done. Nowadays, the modern CT scanners, they have got this AI tool enabled in them. So if you put an abdominal shield, it auto-senses, and the dose which is given, the radiation dose which is given to the mother is actually 40% more than the without the shield. So at our center, what we do is, if we do a head CT scan in a pregnant mother, we do put in a lead shield. This is just to prevent the scatter radiation. But in case you want to do a abdominal CT, then the shield should not be placed. MRI per se, there is no safety data available. The gadolinium, if you talk about, there is no safety data available. So by and large, it's I would say CT scan should be the investigation of choice. And more so, one has to understand if you're doing a MRI for a 3rd trimester mother, and if you have to place her in the lateral decubitus position if she's having some hypertension, it's quite difficult. I think the ICP monitoring, the things are very, very clear and straightforward. If a person requires ICP monitoring, please do it as per the standard guidelines. Let it be BTF or CBIC or whatever guidelines you're practicing in your center, you need to do it. And of course, there is some approach for, there is some scope for doing the pupillometry and other non-invasive measurements. Now, this was a lady who was 27-year-old female who came to us with a history of assault, and she had, as a matter of policy in our center, we do the pregnancy, the UPT test for all ladies who come to us in the 15 to 45 years of age group. She had a very small contusion in the left basifrontal lesion, and we did one CT scan, and there was some fracture you can see out here. She was managed conservatively, and now I think 18 months follow-up we have, the child and the mother are doing absolutely fine. Now the question comes, if a person comes to you with a refractory or a secondary rise in the intracranial pressure, how to manage such cases? I personally believe that the decompressive connectomy or the secondary DC is the best treatment you can offer to a patient, because we have to understand, if you talk about the barbiturate coma or even the hypothermia, there are some associated risks to the mother and to the fetus. So I personally believe they need to be avoided as much as possible in the pregnant mother. Now, this is something which should be talked about. In fact, it is not a part of majority of the guidelines regarding lactation in a pregnant mother who has recently delivered and she's unconscious. What should be the timing of the anti-seizure medication? People have been talking about you should not give barbiturate, you should not give this drug, levetiracetam is the drug of choice. But we should also be talking about the timing of the anti-seizure medication. So ideally speaking, they should be given after the breastfeed or the express milk is taken out from the mother, so that the dose received by the fetus, by the neonate is the least possible. And of course, there have been so many studies available on the same also. Similarly, this lady, she was 39 weeks pregnant, and she had a Rotterdam score of 2, and she had EFAST and other scans were negative, and this was the scan. So we did an ICP monitoring in her, and the same day we did an elective cesarean section. She was extubated 7 days later, and this is 15 months follow-up. Both the mother and the child are doing well, and I think she had a total of 3 CT scans in her. So there have been a few papers talking about how to manage this pregnancy with traumatic brain injury. The bottom line is the management begins in the pre-hospital care, how to position the mother, how to prevent hypoxia, how to look after the blood pressure in the mother, and it continues in the ED, and subsequently till the lactation it has to be continued. Now, if you have a pregnancy, for a neurosurgeon, what are the approaches you should have? If you have a pregnancy which is more than 24 weeks, it's considered to be viable pregnancy. Most of the times, you are able to save those with the advancement in the care. We are able to save those babies. So these are the practical algorithms which we are practicing at our center. Sometimes we have some scenarios wherein the mother is having a fatal injury, and in those cases, you may have to do a cesarean section prior to the delivery. Like what happened in this patient, she was 32 weeks pregnant, and she had severe traumatic brain injury, and this is the CT scan which was done at admission. As you can see, there are large bilateral basifrontal contusions with a mass effect. R score was 3, and she underwent a cesarean section first. The baby was limp, and she had to be intubated, and subsequently we did a decompressive. Unfortunately, the mother died 7 days later, but 15 months follow-up is there, and the baby is doing well. So what it goes on to say is that you have to tailor your requirement based on the nation wherein you are working, because sometimes there is nobody to take care of the baby. Who will take the responsibility of the baby when the mother also dies? So this has to be discussed by the bioethicist in the hospital. And very recently, we have this beautiful publication. At least somebody is thinking in some part of the world, if not the BTF group, to talk about this serious topic. So I think Giuseppe Citerio and the Chiara Robba and then the group, they've actually come up with this paper, the MAMA study. But the results are very, very interesting. What was very interesting for me as a neurosurgeon was there were only 11% of the neurosurgeons were involved in the survey. And where are the obstetricians and the gynecologists? Just 2%. I think when we do this kind of a survey, we need to have a kind of representation from each and every, at least in my hospital, most of the patients are admitted under the neurosurgeons. So probably nowadays, I'm told that the Delphi part 1 analysis is going on, and for the consensus, and probably we will come up with the consensus guidelines on the pregnancy with a traumatic brain injury. And of course, there are some nice observations in this paper regarding the osmotherapy. Most of the people, they preferred hypertonic saline as against mannitol. And most of the people, they avoided barbiturates and the hypothermia in their group of patients. And these are a few messages which were given in this paper. Of course, the family communication is something which is extremely important when we are managing these cases. And in case you are likely to expect this lady to become brain dead or having a severe fatal brain injury, you need to talk to the family about the need for the organ donation. We have to understand that apnea test cannot be done in a pregnant mother with a severe traumatic brain injury because it can be done only after the delivery. So all these things, they have to be discussed. At my center, what we practice, we actually first think, we personally believe one size fits all theory does not work well in these cases. And of course, we do risk stratifications. And in India, we started a campaign called Save Ma. Ma is called mother, basically. And this was just to improve the outcomes in the mother and the babies. And this initiative we started 2 years back and is still ongoing. And we have set down our SOPs. And many patients we have saved, even in the unconscious patient, they've actually gone on to make delivery only with the protocolized management in our hospital for the last few years. And there are many success stories in our country. In the interest of time, I'll skip it. And these are the guidelines that we have kept. And I believe the biggest roadblock is handling the obstetricians. We need to really increase the level of awareness amongst the obstetricians slowly and slowly. So to conclude, I will say that we need to increase the awareness activities amongst the obstetricians and the healthcare workers regarding the CT scan, breastfeeding, anti-seizure medications. Then we need to do the optimization of the systemic parameters in the mother, and every hospital, till the guidelines are there, should have these things in place. And lastly, these guidelines, the multidiscipline guidelines, is much needed. And I believe in a couple of years down the line, we will have the guidelines which will benefit many people across the world. Thank you so much.
Thank you, Dr. Gupta. Do we have any questions?
So maybe I start with a question. So a great talk, especially as you did not cover only the neurosurgical part. You covered the whole theme, and it seems that you're very experienced in that. You're confronted with the problem on daily practice. So what does the consensus add? Where are the main gaps? What do you want to fill?
So I think the biggest gap in my understanding is the knowledge gaps.
Okay.
The knowledge gaps amongst the healthcare workers themselves. As on today, I'm talking on this platform, a lot of people are still unaware that CT scan is safe in the pregnant mother. What should be the hemoglobin level? What should be the blood pressure? How you should position the mother? Anesthesia. Basic things which is needed in a normal person, because people do not understand the altered physiology which happens in the mother. It's a special scenario. The very reason probably the BTF, CBIC and the other guidelines, they did not think about it because they constitute a smaller number of patients. But I believe as we are practicing neurosurgery or neurocritical care, we will come across such cases in our practice. There will be scenarios in your hospital when you're alone and all of a sudden a patient comes, a pregnant mother, 38 weeks, and somebody says she's brain dead. What next? Nobody knows. So for this, we need to have a consensus.
Any other question? So maybe one more. You said that there is an association to a higher ICP level, that especially in pregnant women, which means that maybe also autoregulation is affected otherwise, and which maybe drives you towards using tier 3 decompressive craniectomy earlier in that patient population. Is that the clinical impression you have as well?
Yeah, I personally believe pregnant state is a state because of the increased intra-abdominal pressure in most of these patients. It's a state where the ICP is definitely, people have not done the measurements or done some such study in any part of the international literature to the best of my knowledge. But yeah, it's a state of high intracranial pressure and you need to act proactively. I mean, and you also need to select your drugs, what drug is to be given. I personally believe hypertonic saline is a better drug as compared to the normals, as compared to the mannitol, because of the dehydration and the effect on the fetal lung, kidneys and other things out there. So most of the knowledge which is there with the neurocritical and the intensive care team, I think it needs to be spread and shared with everybody, because the different countries have got different practices. And the biggest flaw in the MAMA study was, this study has been done in the HIC ICUs, high income countries ICU, wherein the maternal fetal mental unit, MFN unit and the neurosurgeon and the pediatricians are there. What about the places where these three facilities are not available? The low middle income countries, developing world. So you need to tailor the guidelines up also.
Okay. If there are no further questions, thank you very much.
Thank you so much.
Then we move to the next talk, which is given by Giuseppe Citerio from Monza, and he's going to talk about moving towards phenotyping in TBI.
Thank you very much. And I think the topic of this presentation will not finish with this presentation because we are moving in the direction of phenotyping, but we are not there. This is the agenda of the talk. I have no conflict of interest for this talk. And the first question is, why do we need phenotyping TBI patient? Because only looking at the CT scan, we have different pathology under the same umbrella of TBI. We have contusion, we have traumatic axonal injury, we have hematoma, and all of them have a different trajectory after trauma. And when we think how we manage our patient and when we think about the early classification where we can do bedside, we can not identify precisely the different trajectory of a patient over a 6-month, 12-month period and also longer. And we need to find a way for better characterizing them, so doing phenotype or endotyping if there is a mechanism bedside on the back of the selection criteria, because we want to understand if our patient outcome goes in a good or bad direction very early. And I think we need to start thinking about phenotyping, because we can have both prognostic association, different treatment planning, different category risk. We need to understand the mechanism behind the pathway of the patient, the trajectory of the patient, and also we can also identify some potential target. Because if you look at the big picture, today we are treating all the patients in the same way. Think about the Seattle algorithm. We have a standardized treatment that sometimes works, sometimes doesn't work. And if we are able to identify better pattern, we can probably identify better treatment for the patient. And I think we can already do something today. Something needs to be done, but we are on the track of doing something in this direction. The first one is thinking about the neurological evaluation. The Glasgow coma scale turned 50 last year, so it's a very old scale, and we are using it I think in a not a proper way, because I used to put the patient in 3 boxes, mild, severe, and moderate TBI, because we think that the risk in each box is very different, but having a Glasgow coma score 15 or 13 is quite different, and so 9, 12 are not the same story, because if you look at the probability of negative outcome over time, this is 6-month mortality, but here in this graph you can see also disability. There is not a cutoff, it's a continuum between the Glasgow. So the first advice for phenotyping the patient is not to use the category way for classifying them, because we have a continuum. So thinking about what you can do bedside, think about the GGS a continuum, but you can also add some other information. Some are already available, some are not available at bedside like biomarker, but they are coming and they are on the market already and approved by FDA. And if you think about pupils, the last edition of the American College of Surgeons guidelines on trauma you can download easily for free. It's written there that pupils response give us some diagnostic and prognostic information, but we still classify the patient as severe, moderate, and we don't keep in account the pupils immediately. And there is also a suggestion to use pupillometry, a strong suggestion to use pupillometry for making a diagnosis and prognosis. Because in the Oregon study we finished a couple of years ago, we were able to understand that there is a relationship between a pathological pupil and a negative outcome, and a pathological pupil and mortality with an increase of risk of 5 times higher if the pupillometry is pathologic. But we didn't think this way the use of dynamic marker like the change in pupils, because if you look at the change in pupils over time, you are able also to change the risk of your patient if you are able to revert a pathological pupil. So if the pupil remains pathological continuously, you have a very high risk. But if you are able to revert with drugs, with surgery, whatever you want, the pathological pupil, there is an association with a reduction of outcome. But this is not enough, because we are facing, we are hearing about patient delivering baby before, but usually my practice see only mainly elderly patient. But I didn't see in the past. I see my mean age of a patient when I start to work was 24. Now the mean age in my unit is higher than 50, 52 or 53. So we need to think about also the aging population. In our mind, being older, being aged, is linked with a negative outcome. But you probably know some very old people playing tennis 80, going on the mountain, being very fit. So think about also the reserve of the patient, frailty of the patient makes an important point. You calculate the frailty index in the center TBI collaboration, and we will see, we will discuss about center TBI more than once in this presentation. And we saw that the probability of being frail is much higher when you are older, but also is present in all of the lifespan. And if you look at the age of the patient, higher than 18, higher than 30, higher than 60, and the frailty increasing from 0 to 0.6, white is death in all the boxes, you can see that it's not only age, but at the same age, the patient is exposed to a different risk according to be frail, not able to compensate the trauma. So we can already insert some information of frailty in our early evaluation. So starting from today, we can classify the patient better looking at the full spectrum of GCS, insert the pupil in your reasoning, and think about the frailty of your patient. The approach of phenotyping uses also some fancy biomarker, and I think they are very important because in red there are the biomarkers we tested on, we sampled in 5,000 patients in center TBI. All of them have different cynetic, all of them are coming from different brain area, and you need to understand where they are coming from. But generally speaking, we can use biomarker for different reasons. The first one is to have an idea of severity of your patient, and we will see how biomarker could help. The biomarker that now are released by FDA to be used bedside could help you identify severity of the patient, but also you can use them for the progression of a disease or for looking at the result of intervention. Thinking about severity, we have patient here with a Glasgow 13-15, with a negative CT scan, with a positive CT scan, higher here is 9-12 and below 8. As you can see, there are different quartiles, but the color is a different Glasgow outcome scale category, means how the patient goes after 6 months, and 4 is the category, is the broad category we are using for separating good and negative outcome, even if we want to see also here a continuum. But as you can see, as much as biomarkers are released in all the different spectrum of the disease, as much as the patient have a negative outcome, even if you are severe, because you think I'm severe from between 3 and 8, who cares about biomarker? As much biomarkers are released, as much the patient will be in a worse outcome. We did the same on the secondary insult. So also hypotension and hypoxia could provoke an increase of biomarker because there is a damage in the early phase of the disease out of hospital. And we published a paper in which we saw that hypotension and hypoxia are more relevant in producing a neuronal damage and not an axonal damage and not a glial damage. But also you can think about inflammation post-TBI. Contusion and other lesion promote inflammation. And looking at different release of inflammatory biomarkers, we can have different outcome. There is a group of patients that doesn't release so much, and a group of patients that there is a lot of biomarker with inflammation. There is an association with a negative outcome. And if you put information together, the severity, biomarker, age of the patient because it's important, inflammation, yes or not, extracranial injury, and you look at the final endpoint you want to look at, the outcome Glasgow scale, the release of circulating cytokine biomarker of inflammation is much stronger associated with outcome. Is less associated with the presence, for example, of extracranial injury, but makes the situation more complex, because biomarker could help, but we need to understand how to use them at the best side. We can use them for selecting imaging. There are a lot of papers that give us information about selecting the lesion type according to biomarker for identify, for example, traumatic axonal injury. The lesion number, more biomarkers are released when the lesion number is increasing, is documented also by Center TBI, and also help to classify the CT scan looking only at biomarker. This is useful mainly in less severe patients, because we need, for example, to ask ourselves if we need to have a CT scan or not. But look here, there are patients with, let's say, quite normal clinical evaluation, patient 9, 12, and 3 and 8. And as you can see, the release of biomarker in this category is quite high, but it goes up. The more severe patient have a higher release of biomarker. But also in the category of the less severe patient, you can see you have 4 quartiles. There is a quartile in which biomarkers are released similarly to the patient with a more severe damage. And in this case, the positivity of CT scan is much, much higher. But also the outcome of the patient is influenced, even if they are not so severe, by biomarker. And there are some classification and some cutoff of biomarker level because biomarkers are already on the market. But also we can look at the progression of the disease. For example, biomarker goes up and down over time. This is microdialysis, this is serum. It doesn't matter when you sample them, but the increase or some biomarker was associated with negative long-term outcome. But also we can use as biomarker also the information about the connectivity of the brain. A study at magnetic resonance, the so-called connectome, is really connected with long-term psychological outcome. So it could be important in less severe patients. So I think that also imaging could help us in better defining the patient, and the information we can get by biomarker could help us in selecting the patient. I show you only 2 experiences in which 3 experiences in which biomarker has been used and phenotyping has been used. This is a paper from Cecilia Ackerlund. He was looking at the category, you're looking at the best side, but he was classifying, for example, for the severe patient, normally at the range metabolism. These are normal patient with a damage, with a patient with a severe brain damage, these are patients with hypotension, with bleeding, with other with other extracranial problem and severe damage. The release of a biomarker, we can go in deep detail in this case, in the different category, as you can see graphically, is quite different. But what's striking, that in the same category, looking at different profile, mortality and disability are much different. So phenotyping matters. And so looking at big data set, you can track TBI and the mimic data set, they try to cluster with a clustering approach, different phenotyping. And in the yellow are the more severe patients, more severe clinically, but also they were able to classify 3 classes in the 2 databases, but also the lab, glucose, hemoglobin, hematocrit are different in the 3 data set. And looking at the clustering, you are able to identify 3 clusters putting together lab value, clinical examination, CT scan, and there is a different mortality, higher mortality in the yellow category in this study. It's been done also in Center TBI by Cecilia Ackerlund, trying to clustering representation of trajectory after trauma, and she defined 5 groups in which Glasgow, glucose variation, and biomarker, return back here, are the key descriptor of a disease. But in the supplementary method, she added was also that mean ICP, CSF drainage volume, creatinine sodium variation were associated with outcome. Why does it matter? Because the different category that looking at the patient you cannot identify, but putting this information together, you could identify are associated with different mortality. And so going to the conclusion, I think that we have 50 seconds. I think that we are starting to be able to stratify the disease. We are not yet there because because we are able to cluster them. We are able to cluster them and classify different outcomes, but we didn't match the class of a patient with a therapy. So the conclusion is that having an heterogeneous disease is quite natural think about phenotyping, but also in our mind we are phenotyping the patient where we are treating the patient. And I think what has been said, biomarker, advanced imaging are coming out as a useful tool for making a better classification for the patient. And I think this will be something for a key step toward trying to matching therapy with the different category in which the patient is classified. And probably as we discussed also this morning, we are not classified, probably Elena skipped this, we are not more classified patient as mild, moderate and severe usually, but we look at the spectrum of the disease. Thank you very much for your attention.
Thank you very much for the great talk. Are there any questions? So, alluding to the best practice guidelines, I think that's very important because there's so many practical information, and I think you contributed to that as well. So, congratulations to that. Phenotyping TBI patients, you said something about the diagnosis, CT scan, yes or no, for the emergency setting, about prognosis a lot. I think that's also a value. You briefly touched on the management as limitation. What could be a management based on phenotyping the patient? Which management strategy would you study in a clinical trial? If you want to select a phenotype and say, well, that's going to be likely a phenotype who's going to profit from a specific intervention.
The first point is that you need to find a dynamic predictor that you can follow over time. For example, having a serum biomarker, you need to understand which is the half-life, because if we want to see a response to a therapy, we need to understand which biomarker is better to understand if the patient is reducing the damage. For example, in a trial we are doing, you know it, about mesenchymal cell, we are using biomarker for understanding if the response could be seen with an indirect sign, because we are not waiting 6 months, but we are looking at the immediate response, yes or not, understanding if the biomarker goes down or are not going down and going up. So I think we can integrate the response to our therapy that today, you know, are not so solid based by evidence, but we are using, for example, mannitol hypertonic saline every day, and the endpoint is the ICP, but we can also identify better which patient require one or the other if we are able to phenotype, for example, brain edema, the opening of the blood-brain barrier. So the field is very open because I think we start now to understand that we need to phenotype. And the lecture was moving toward phenotype, and we are not there, and I think artificial intelligence and that means bigger data set will help us understanding pattern, understanding suggestion of the therapy, response to therapy, and we need to classify the patient against, for example, a sample patient that has been classified by a large data set. Has been presented this morning in the opening ceremony, something similar in using vasoactive drugs.
You've spoken a lot about blood biomarkers, very appropriately so, but not so much around the new approaches to magnetic resonance imaging. And I wonder if you see potential value in the what is currently experimental, or even in current clinical practice, MRI images for phenotyping as well. Things like tractography, for example. Are they going to complement biomarkers, or perhaps even be more valuable?
It is a very large chapter, the use of imaging like a biomarker. It depends on what you want to understand. If you want to understand if a patient will be conscious or not later on, you can do some sequences looking at the connectomy. If you're looking at some area in which there is disturbances of emotion, you can search something else. But you use it usually as second-level search, with a second-level evaluation. And I think another point I didn't touch, the previous speaker came from India. We need to think globally. Something could be done everywhere. The clinical exam, pupils, the CT scan is almost done everywhere. biomarker, if they will become cheaper, they could be done. There are point of care of biomarker, but they cost money. If the price goes down in the future, probably it can be more diffuse. And the using of imaging, except CT scan, MRI became something that only some country could afford today.
Any other questions? So maybe one additional brief question. You found an association between biomarkers and hypotension and hypoxemia, which is great. So what?
No, what we were surprised to see that, for example, the level we are thinking about, a level of hypotension and hypoxia, saturation of 90 and 110 millimeters of mercury of 90, like cutoff point of a traumatic coma data bank, have different effects. And so probably the tolerability of hypoxia in this setting did produce less release of biomarker. Probably the threshold is quite high, 90% of saturation or 60 of millimeters of mercury of PO2. And the effect of hypoxia was much bigger, and the combination of two was important. So, but the release of biomarker was linked to a worse outcome in this setting, even if the patient doesn't have the secondary insult. So the secondary insult it was associated with an increase of biomarker, and they had an impact on the outcome of the patient. But also we were able to differentiate the two insults because in our mind they are similar. Hypotension and hypoxia are two enemy, and probably hypotension in this setting it was due to the threshold, not due to mechanistic elements.
Yeah, I think that's an important discussion and an added value of phenotyping patients to see how the amount of the injury burden in whatever hypoxia, ICP or whatever contributes to the damage. And I think that's great. So thank you very much again.
Thank you.
Our next speaker is Marc Maegele, who comes to us from Cologne. He's going to talk to us about coagulopathy or hemostatic failure in TBI. Marc.
Yeah, thank you, Michael, and thank you for being here. And it's obviously very difficult to talk after Giuseppe, after such an interesting topic. In this particular context, but please allow me a brief comment with regard to transfusion and trauma, especially in TBI. And you probably may remember the US-based plasma trial, the PAMPER trial, published in the New England Journal, it was 3 or 4 years ago, where basically those colleagues in the US gave 2 units of plasma to bleeding trauma patients. And what they observed was they observed a survival benefit. Another study that almost was published simultaneously in The Lancet came from Denver, using a similar approach, but did not show an effect. The interesting thing with the study from Pittsburgh was from the PAMPER trials that exactly the colleagues did phenotyping. And what they found was they linked their effect of 2 units of plasma to trauma patients to a very strong effect in one subpopulation of that study, and that was TBI. And they found out that these patients were UCLH biomarker positive TBI patients. So this basically reminded me a little bit of the previous talk, where basically phenotyping could also be useful in guiding transfusion or use of blood products in bleeding trauma patients, especially in patients with TBI. And this will comes back to the topic of my talk, whether hemostatic failure, coagulopathy after TBI is related to the injury itself or could be used as a modifiable risk factor in terms of addressing this entity early and thereby improving outcomes. And what we also know from retrospective data analyses was that the trauma patient essentially still dies from 2 causes, and one is TBI and the other one is hemorrhage. And in the context of center TBI, we looked at the literature, and looked what is the prevalence of those entities occurring simultaneously in one patient. And we came up with that percentage of around 30 to 40% of patients after having sustained a traumatic injury, that those patients also develop some form of hemostatic failure that is ultimately related to outcome. As you can see here, that the mortality in patients with TBI and hemostatic failure may be up to about 50% with an odds ratio for mortality of 9.0. And as we all know that this hemostatic failure after TBI or occurring in the context of TBI is highly dynamic. And on the left-hand side of that cartoon, you see a CT scan on admission, not very severe bleeding, with an almost compensated coagulation profile. So we took this patient to the ICU. 3 hours later, the patient was taken back because this patient deteriorated, developed neurological symptoms, and you can see the CT scan along with severe development of hemostatic failure of what's also referred to as trauma-induced coagulopathy. And on the right-hand side, this is a paper that came out more than a decade ago, but it nicely shows you that the number of patients that arrive in the trauma bay after having sustained a severe traumatic impact, those numbers of patients in hemostatic failure, in hemostatic problems, they may double within the first 24 to 48 hours. And this is one of the very few prospective observational studies came out in Germany looking at hemorrhagic progression in those patients. And in those 153 TBI patients, the frequency or the occurrence of hemostatic failure was about in every second patient. And that was basically evidenced on follow-up CT after 6 hours. And hemorrhagic progression had a hazard ratio for unfavorable outcome at discharge and after 1 year. And the risk of developing hemostatic failure obviously is even increased when those patients are under pre-injury anticoagulants or antiplatelet agents, as shown here in that study we conducted also in context of center at TBI. And if people die from acute exsanguination or if they die from hemostatic failure, they do this very, very early in the sequelae after hospital arrival, usually within the first 6 to 8 hours. And the sooner we get control of the bleeding source and the sooner we are able to restore hemostasis, that is clearly associated with outcome as outlined here in 400 patients. This is a subgroup from the US-based PROPER study on 400 patients with every 15 minutes in decrease to hemostasis. This was clearly associated with a survival benefit. And this is also translated in the updated European trauma guideline, but also in the updated guideline for perioperative anesthesia, but also as outlined here in our national trauma guideline, that the monitoring of hemostasis is an integral component within the first minutes the patient hits our ER doors. And as you can see here, there is an increasing advice, or it's increasingly being promoted not to use conventional coagulation, plasma-based coagulation tests like PT, RPT, or PT ratio, with only respect maximum for 5 to 10% of the entire thrombin generation, and with usually very long turnaround times. Instead, it is highly recommended now to use more or less sophisticated viscoelastic testing assays that more or less reflect different aspects of the coagulation process, and thereby providing a much more rapid point of care driven information of the whole kinetics of hemostasis by the clotting time, which reflects the initiation of clotting, the quality of clotting, and the stability of the clot that's being produced in the cup. And those results can easily be translated into different algorithms that basically provides a stepwise approach on how to address specific hemostatic deficiencies in bleeding trauma patients, in those including TBI, starting from lysis onto stability and onto initiation, thereby suggesting different approaches of therapy. For example, if you want to block the lysis, you need an antifibrinolytic drug, for example, tranexamic acid. If you want to promote stability, clot stability, you need to add substrate in form of fibrinogen. Or if you have a prolonged time in clot initiation, the CT time, then you have a problem with thrombin generation, and then you need clotting or coagulation factors. And this is just a quick excursion how we work in our trauma setting. This is a severe traumatic brain injured patient, and this was the first rotem trace that we detected in this particular patient. Once the patient was delivered into our emergency department, you see a complete absence of fibrin polymerization as evidenced as a flat line in the FibTem. You see the deadly shaped diamond in the XTem and in the INTEM, which basically reflects a severe form of fibrinolysis. And when you look at the EPTEM, that's exactly when the XTEM was added by a protein or tranexamic acid. Then the fibrinolytic pattern was completely reserved in vivo. So this was clearly indicative that this patient was responsive to the administration of tranexamic acid. Then the patient was put into theater, and according to our guideline that we have in place in our setting, this patient was treated with 2 grams of tranexamic acid. Remember, you need to block the lysis first before you add any substrate, because if you have ongoing lysis in the particular patient, you can add much substrate as you want. You will never generate a sufficient clot. But as you can see here in that sequence, given 2 grams of tranexamic followed by 4 grams of substrate fibrinogen, we were able to generate a sufficient clot, but the patient continued to bleed. Again, fibrinogen was administered, and once the patient was operated, he received a dura extension patch. We were able to hand over the patient to the colleagues from the ICU with a normalized coagulation profile. Is it easy to translate or to implement such an algorithm to a center, initially naive? And Giuseppe already mentioned the Center TBI initiative. And in this context, we were able to recruit 4 centers out of the Center TBI network that were willing to accept and to be trained to such an algorithm. We staffed these centers with machines and trained the local personnel in 4 European trauma centers affiliated with Center TBI. 32 patients were analyzed, and there was complete adherence to the algorithm in 20 out of 32 cases. What we also observed was that actually viscoelastic testing as being trained now to the local personnel was much more sensitive in picking up coagulopathic signals. And what we also observed in that study and what we confirmed is the more rapid turnaround times for ROTEM or viscoelastic testing test results that allowed us to activate our treatment algorithms much earlier in those bleeding trauma TBI patients. What we also observed that the adherence to the algorithm was clearly associated with better clotting, clot structure, and clot initiation, as evidenced by the corresponding viscoelastic testing traces. This is one of the very few prospective studies that basically assessed the clinical value of implementing viscoelastic testing assays and treatment algorithms. Was a prospective case control study in patients with TBI craniotomy, including 134 patients. Here, 34 cases were coagulopathic and showed road-term abnormalities, and 24 of them were treated to the algorithm. The adherence rate to the algorithm was quite high, with 85%. And what we observed, or what the authors basically reported, was that ROTEM, or the use of viscoelastic testing assays in those bleeding TBI patients, led to a more consistent coagulation management that was also reflected by the corresponding ROTEM parameters pre and post. But what was also interesting to observe was the clot quality dramatically improved, and there was a decreased incidence of progression of their initial intracranial hemorrhage, and a less need for a neurosurgical re-intervention. Last but not least, I would like to close with the results from our iTactic study that was conducted in the context of our pan-European trauma network involving 6 major trauma centers across Central Europe. In this context, we conducted a prospective multi-center randomized controlled trial to compare the hemostatic effect of 2 optimized evidence-based goal-directed transfusion algorithms. One was based on VHA, the other one was based on coagulation, on conventional coagulation assays. Almost 400 patients could be included in the trial. We randomized to both arms in addition to standard of care until hemostasis was essentially achieved, and the primary endpoint was the proportion of patients alive and free of massive transfusion at 24 hours. Well, there was no effect, or only a marginal effect, observed in the intention to treat trial. Interesting, we saw a huge effect, or more pronounced effect, in those patients arriving already coagulopathic in the trauma bay. And the most strongest signal we observed was in patient with TBI, where both mortality endpoints became statistically significant. So take-home messages are exsanguination and TBI remain major killers after trauma. Hemorrhagic progression occurs in up to 40 to 60% of all TBI patients. As promoted by the vast majority of guidelines at present, is that measures to monitor and support coagulation of hemostasis and early restoration of hemostasis is key. Viscoelastic tests provide fast test results due to their improved turnaround times and are superior to conventional coagulation assays in picking up coagulopathic signals. Goal-directed treatment algorithms have been implemented, have been produced, have been validated based upon viscoelastic testing, have been introduced and may be associated with improved outcomes. I've not talked about reversal agents. Antidotes obviously are available. We have PCC for warfarin reversal, and we have novel specifically targeting antidotes for 10A inhibitors and thrombin inhibitors. This should also be considered, especially as those patients on pre-injury anticoagulants are prone and have a higher risk of developing hemostatic failure, even a higher one than regular patient with TBI. And with that, I would like to thank you for your attention. I'll be taking any questions if you have. Thank you so much.
Marc, thank you for a very clear talk. While people are thinking of questions, I see there's a lot of people standing up the back. There are many, many seats down the front, so please do come down. Are there any questions for Marc? Yes, over there.
Hi, may I ask, you follow the hemostatic assay to give the transamin. Do you prefer following the hemostatic assay result or going for, for example, empirical crash trial dosing?
So the question was when to give tranexamic acid to block lysis, correct? Whether we should await signals from viscoelastic testing or not. In the European trauma guideline, we clearly advocate against waiting because we anticipate in those patients a high risk of fibrinolytic hemostatic derangements that needs to be addressed at a very early stage. So, and also given the fact that based on CRASH 2 and CRASH 3 trials, and also the recently published PATCH trial from a consortium in Australia, New Zealand, and Germany, tranexamic acid has become a mainstay and key component of pre-hospital therapies. And in the PATCH trial, we clearly advocate TXA as a pre-hospital intervention where you basically don't have anything to measure. You need to give it blindly, and this is usually based on the results from CRASH 2, CRASH 3, and the PATCH trial. So then we give it empirically. Once the patient is in the hospital and we have access to viscoelastic testing, we obviously do a test. We see it very early, within 5 to 10 minutes of test initiation, whether that particular patient potentially needs a second dosing, or if we are well off and add substrate in terms of fibrinogen or coagulation factors itself.
Thank you.
So, Mark, I've got one more question, quite broad, really. Why do some people become coagulopathic and others don't? Is it just the nature of the TBI, or is it something else about their makeup?
So I think it's a very complex picture. Some people, there may be different forms, and we are currently looking into different forms of fibrinolysis. And I'm sure you're also aware of the work from the Denver group, now identifying 7 different phenotypes of lysis. So I think the coagulation system responds in general to some form of impact. Whether the patient develops or which phenotype actually the patient develops might be related to the injury, to the impact itself. For example, shock being a principal driver of the hyperfibrinolytic phenotype of coagulopathy, while large soft tissue trauma more or less is associated or has been associated with shutdown fibrinolysis. So there is still work to do. We have identified several key elements that potentially drive TIC, and one of the major drivers obviously is related to shock, hyperperfusion and endotheliopathy. That then drives the more or less hyperfibrinolytic phenotype of trauma.
Thank you.
One more question on isolated TBI, because I think you touched lots on polytrauma and also tissue damage and coagulation. So would you recommend also tranexamic acid for isolated TBI in the pre-hospital area?
Yeah. There is, I think, well, this is my personal view on I've served 15 years on our local helicopter, and it's quite challenging to make a decision based, let's say, on very limited information. You are gaining in very, very, very limited time. Based on CRASH 3, there is a reported and benefit in patients with mild to moderate, with still reactive pupils. So in those patients, I would give it in an isolated context. We also basically saw benefit in our study and also in the PATCH 2 trial. In the PATCH trial, I think TBI needs to work up in that context again as well, but we have seen in that subgroup also a benefit. And potentially in those patients with severe TBI, what can you do? What can you do wrong? I mean, so during my last days I became very liberal, and I gave it to patients in shock based on pathophysiology, and I gave it to TBI patients regardless of severity. But that's my personal opinion.
Okay, yeah, I think expert opinions are very important, weighing pros and cons, and obviously it's a decision of the center or the region to do so. So thank you again for the talk, and we proceed to the next speaker, Elisa Bogossian from Brussels. She's going to talk about transfusions in TBI beyond hemoglobin targets. We're looking forward to that.
Hi everyone, thank you for the invitation. So yeah, we're going to start. Is there something else that we should be looking at when we decide to transfuse a TBI patient? And why are we posing this question? Because last year, 2 important clinical trials tried to answer the question if we should, when should we transfuse TBI patients? And the first one to be published was the emotion study, and they showed no difference between 2 groups of patients, one randomized to receive red blood cell transfusion at 8, considered the restrictive group, or a liberal group, which was the transfusion was started when hemoglobin levels were below 10. The other trial, the TRAIN trial, showed an improvement in a reduction in the risk of unfavorable outcome at 6 months, but it was a mixed population of acute brain injury. When we look specifically at TBI, which we did, it does seem that most of our results are driven by the TBI cohort, which was the biggest one. There is an important reduction in the absolute risk, but in the relative risk, it still touches the 1. So why do we transfuse TBI patients? So we transfuse TBI patients because we know that anemia is associated with poor outcome and is a cause of secondary brain injury. And why is it a cause of secondary brain injury? Well, because anemia, so low hemoglobin levels, are associated with the reduced oxygen delivery. This is the formula for calculating oxygen delivery. It's cardiac output plus cardiac arterial content of oxygen. And in the context of the brain, we use it CBF. And as you can see, the formula for arterial content of oxygen includes hemoglobin. So we transfuse in the hopes of increasing oxygen delivery. And why would we target different hemoglobin trigger in traumatic brain injury than we do in the general ICU population, where we know that 7 appears to be a reasonable target? Well, because usually you have a constant oxygen delivery, and as hemoglobin falls in the normal brain, compensatory mechanisms are activated to increase cardiac output, to increase oxygen delivery, and you have extraction rate that remains relatively stable. However, when you achieve this compensatory mechanism of increasing cardiac output, oxygen delivery starts to fall. And to compensate that, the tissues start to extract more oxygen, and then you have an increase in the oxygen extraction rate. And this, in a healthy brain, occurs around 6 grams per deciliter of hemoglobin. However, when we look at the injured brain, it's a bit different. So, especially traumatic brain injury patients, in the context of polytrauma, for example, they have difficulty in maintaining these compensatory mechanisms. So, CBF does increase temporarily, but then rapidly in higher levels of hemoglobin, around 8 to 9, you start to have a decrease in oxygen delivery, an increase in the oxygen extraction rate. So it makes sense to think that maybe we need a higher target of hemoglobin. The general principles of transfusion are, first, to minimize risk, and there are risks associated with transfusion. It can be considered as an organ transplant. To improve outcomes, not just correct anemia, right? and to optimize resources. So blood is a rarity. We don't have it available for everyone, so we need to choose well our patients. And since hemoglobin, since transfusion, the objective is not just to correct the hemoglobin level, but the actual target is to increase oxygen delivery, it makes sense to not just look at the hemoglobin level and look at other factors, which is what we do daily in our clinical practice. We just don't look at a number and decide to do anything. We see the full clinical picture. So, and there's some patients that we tolerate lower levels of hemoglobin, and some patients that will not tolerate lower levels of hemoglobin. For example, usually when the anemia onset is chronic in general population, these patients tend to be relatively asymptomatic. Whereas when anemia is an acute event, for example, in hemorrhagic shock, and just remember that TBI patients associated with polytrauma, they can have hemorrhagic shock, then you don't even look at hemoglobin levels, right? The treatment for hemorrhagic shock is transfusion. We also think about the baseline conditions of the patient, and we look at their comorbidities, because we know that maybe patients with already ischemic heart disease might need a higher trigger, for example. We do look at hemoglobin levels, but it would also be interesting to look at the physiology of DO2, oxygen delivery, and VO2, oxygen consumption. So in the general population, we can have potential additional triggers, which have been studied, albeit small studies, in sepsis in general, where you have a very similar graph that I showed for the brain, but here in the body as well. You have a phase where DO2 is constant and VO2 is independent of DO2. So you have more oxygen delivery than you have oxygen consumption. However, you reach a point, which is the critical DO2, where DO2 starts to decrease and compensatory mechanisms are insufficient. You increase the oxygen extraction rate, and this is seen with a decrease in the central and mixed venous saturation. This is seen as an increase of the oxygen extraction rate, potentially an increase in lactate levels. But how can we adapt this to the brain? So, one way to do it is use brain oxygenation, right? If the target of transfusion is increasing oxygen delivery, so let's look at how much oxygen is getting to the brain. This is brain tissue oxygenation, but just to remind us that it's not just a marker of oxygen delivery, right? Because you have perfusion, sure, but you also have diffusion of the oxygen from the blood vessels to the cells, which in case, for example, of edema, may take longer. And we have the consumption, right? The local metabolism, because of autoregulatory mechanism, we can adapt. There's a coupling. So, for example, if you have fever, you're in a hypermetabolic state, or seizures, you will consume more, and this may reflect in a lower PbTO2. But regardless, it's still an invalid trigger. So, the first thing to see if actually transfusing just actually changes brain tissue oxygenation, right? We don't know. So this study was a secondary analysis of the effect of erythropoietin on transfusion thresholds. It was a 2-factorial design, so patients were randomized to placebo erythropoietin, and the same patients were also randomized to 2 different hemoglobin thresholds. So, looking at the hemoglobin, just look at the patients, considering just the transfusion thresholds, 200 patients were randomized, and here we can see that the gray light is threshold of 7, and the black lines are threshold of 10. You can see that in the beginning, at least in the first 100 hours after ICU admission, there's an overlap, right? That continues, maybe it separates here, but then it overlaps again. And this was true regardless of the probe location. And this was also true regardless of CPP, so cerebral perfusion pressure, because maybe it wasn't the hemoglobin target that was making a difference, but maybe you had an area that was better perfused than others. But in fact, there's an overlap on cerebral perfusion pressure, right? Really does overlap. So that study didn't show any difference in PbTO2 regarding two different threshold levels. However, this is a small single-center perspective study from 2009. This group evaluated the response of PbTO2 to transfusion as well. And here we can see that, Here we can see that some factors were associated with a change, an increase in PbTO2 level following transfusion. And the factors that were significant was PaO2, which makes sense as part of the technique. We know that if we increased partial pressure of oxygen in the blood, we do increase PbTO2. It was also associated with cerebral perfusion pressure, which also makes sense because you need to get the blood flow there. And it was associated with the hemoglobin levels. So as you increase hemoglobin level, you increase in PbTO2. This study, also small, only 60 patients, they identified that in 78% of patients there was an increase in PbTO2 following transfusion. And they wanted to see if they could separate groups that would respond to the transfusion and groups that wouldn't respond to the transfusion. And here we can see that they separated patients based on a cutoff of 15. And 100% of patients at 3 hours responded to transfusion with an increase of PbTO2, and 78% continued to have this good response in 24 hours. This is in patients with brain ischemia, right? Low PbTO2. In patients with normal PbTO2 or adequate PbTO2, you can see that there was also a response, but it was in a smaller group, so 75% of patients. Even less so when you looked at 24 hours. And in here, they plotted the difference in PbTO2 from before and after transfusion at 3 hours, and the baseline PbTO2. And you can see that the higher difference in PbTO2, so the increase in PbTO2, is more important when you have lower levels of baseline PbTO2, which maybe mean patients that weren't getting enough oxygen are the patients that benefit from transfusing. Our group, together with Innsbruck and Lausanne, also evaluated the effects of blood transfusion in acute brain injury patients. Part of these patients were TBI, 21. And here we can see that we assessed 69 patients with 109 episodes of transfusion. And we had a variable response. 78 patients, which is 72%, close to the other study, the PbTO2 increased. In 8 patients, 7%, there was no change. But in 21% of patients, PbTO2 actually decreased when we transfused them. So the overall result was an increase in PbTO2. But we also don't want to cause harm in these patients, right? The ones that didn't respond. So we decided to assess if we could identify a baseline before transfusion, characteristics that would help us see which patients would respond in terms of brain oxygenation. And here we can see that heart rate and the baseline PbTO2 was associated with the response. So here, the higher the baseline PbTO2, the most important increase. So to say, the lower the PbTO2, the more important the increase, and the heart rate was directly, so the higher the heart rate, the most important the increase, which makes sense because an elevated heart rate may represent symptomatic anemia, for example. And we did a ROC curve using baseline PbCO2 values and adequate response, which we called an increase in PbCO2 bigger than 20%. And we found that the best cutoff with sensitivity specificity was 20, which is usually the cutoff that we use to start treatment. How about other mechanisms to measure brain oxygenation? So the jugular venous oxygen saturation was really used a lot in the past. And why would it potentially be a trigger? Because in a normal situation, you have 100% of oxygen saturation in the arterial. You have a normal cerebral blood flow, which leads to a low arterial venous difference of oxygen. And you have oxygen extraction at normal levels, which leads to, for example, SjVO2 of 75. However, if you have a low CBF, even if you have 100% of oxygen, to maintain an adequate level of oxygen delivery to the tissues, you have to increase the extraction. So this increases the difference between the oxygen in the arterial cells and the oxygen in the jugular vein, leading to a reduction in the saturation. And there are a few studies that assessed the impact of transfusion in the oxygen saturation in the jugular vein bulb. This is also a subgroup analysis of the erythropoietin trial that I mentioned before, and they identified 59 patients that of the 200 that had pre and post values of venous saturation at the jugular bulb level. And here they looked at, so this is the overall population, right? And we can see that pre-transfusion was 73, the median, and post-transfusion was 76, which you may say, is this really clinically relevant? But it was statistically relevant, okay? So there was an impact. And when they tried to see, well, what would be associated with this post-transfusion SjVO2, and obviously pre-transfusion was, because they're correlated samples, right? But interestingly, the threshold used for transfusion was not associated. So being randomized for 7 or for 10 did not influence the response of the brain oxygenation to transfusion. With the jugular vein catheter, we can also calculate a series of other physiological parameters. And I would like to highlight that we could potentially calculate the oxygen extraction rate, which has been studied in septic patients, and maybe an additional target. But there are no studies assessing this in TBI. The other possibility that we have is near-infrared spectroscopy, so a non-invasive tool. And basically, we have 2 electrodes. One is having the light stimulus, the other is capturing it. And then you can have a regional cerebral oxygenation that is almost the equilibrium between the venous and the arterial oxygenation. So it's also a possible way. Of course, there are many caveats with NICs, but this has been studied. So the group from Canada wanted to see if you using this, you could see a difference in NIS in the regional saturation of oxygen after transfusion. And here, they separated by probe location, but you can see it's a very variable response, right? They only included 19 patients, so in blue, patients that increase the regional oxygenation, in red, patients that didn't increase, that actually decreased, and in the traced line, patients that remain pretty much the same. And this was true in both locations of the probe.
You got 1 more minute.
Just finishing. So here, they tried to identify what were the patients that would respond, the NIS would respond to transfusion. And we can see that the only factor that maybe is associated in the left side was the MAP. Nothing else, especially not the hemoglobin change or the transfusion threshold, were associated with the change in regional oxygenation. Another thing that you can use NIS for is to calculate the fraction tissue of oxygen extraction, which is kind of the extraction ratio, which is the subtraction of oxygen saturation, arterial saturation, and regional saturation, and so divided by arterial saturation. And we can see, unfortunately, in the group of the restrictive group, there were no baselines, so we can't really have any conclusions. But we see that even after transfusion, the oxygen extraction was higher in the group that was only transfused when hemoglobin was less than 7. And this was I'll go fast, it was just one trial, randomized pilot trial, that in patients who had hemoglobin between 7 and 10, they were allocated either to be transfused based on a hemoglobin target of 8.5 to 10, or based on the regional cerebral oxygenation, which they looked, if it was below 60, they would transfuse, targeting the same hemoglobin. And what they saw is that it was feasible to do so, but there really wasn't a big difference in the level of hemoglobin. And the only thing that they found was that patients randomized to using a NIS received less units of blood per patient included in the study. But the difference was 1 to 1.5. So I'll skip cerebral metabolism. And just to conclude, to integrate everything, so you have a traumatic brain injury patient that is severe. You want to know if you should target Libero, so 9 or 10. You can look at physiological systemic targets, including ongoing myocardial ischemia or the presence of tachycardia, even though they are adequately fluid resuscitated, respiratory failure, and you can also check normal parameters like lactate or SvCO2. And we can also look at the brain, so we can use PbCO2 if it's less than 20, regional oxygenation calculated by URIS if less than 60, and jugular vein if less than 55. Just to finish, we want to transfuse to increase oxygen delivery, not to correct anemia. So hemoglobin targets, they should just be used to consider transfusion. A complete clinical assessment is important. And perhaps we still need randomized clinical trials or large prospective studies to see if you can use brain oxygenation as an additional trigger. Thank you.
Thank you very much. We are a bit over time.
Yes, sorry.
And I think your conclusions are very, very clear. Look at physiology to transfuse. Thanks again for the talk. And we're going to proceed to the next speaker, which is Chiara Robba. She's going to talk about mechanical ventilation in TBI. Please.
Good afternoon. Thank you very much for the invitation. And I think that the common point of all the talks so far is that at the end of the story, TBI is a systemic disease. because we have involvement of coagulation, we have problem with transfusions, and we have also a lot of problems with a mechanical ventilation. This is a sort of agenda of what we will discuss today. I want to provide you a sort of bit of a story of a mechanical ventilation in brain-injured patients, a story which starts with this paper from Geert Meyfroidt, which exactly explains us why traumatic brain injury is a systemic disease, because there is a first initial intracranial damage which then triggers a number of pathophysiological and inflammatory activation factors which cause a sort of first hit to the peripheral organ probably, and that make them more vulnerable to complications. But then we also need to keep in mind that sometimes when we treat patients with a brain injury, we treat the brain but at the expenses of other organs. Let's think about, for instance, the hypothermia or the need for hypertension, the need of high doses vasopressor, neuromuscular blockers for the management of ICP, and the other way around. So this results basically in a very high number of pulmonary complications. I think we can discuss at the end of the talk why there is an important reduction of the pulmonary complications in this population, but up to 10 years ago, the incidence of ARDS was very, very high. It was around 25%. And in a pooled analysis of all the studies, we are around the 19%. And this is an important problem because, of course, this importantly influences the outcome, a complication like this. So, how do we ventilate our patients? It is a big problem because there are really few evidence. If you take all the randomized control trials that have been published from the Provenet group in the general ICU population, and you look at the exclusion criteria, very often you will find neurological patients. They have demonstrated that we need to be protective in terms of ventilation. We need to use low driving pressure. We need to use low plateau pressures. And this is regards not just ARDS patients, but also non-ARDS patients, like also in the perioperative setting. Why brain-injured patients are among the exclusion criteria of all the trials that brought to this? Because there are some pathophysiological concerns regarding the use of lung protective strategies and this kind of ventilation. First of all, because you have to think that if you have a brain edema, one of the first mechanisms of compensation is basically the venous outflow. So everything that causes an increase in the pressure in the chest, in the thorax, might reduce the outflow at the level of a jugular vein. So let's think about high PEEP or the recruitment maneuver, etc. At the same time, basically, there is a problem with intrathoracic pressure and its hemodynamic effect. We know that hypotension is one of the major causes of secondary brain damage. So if we do a recruitment maneuver and this causes important hypotension and reduction of the CPP for brain-injured patients, this might be a problem. And then there is another important point, because if you look at the guidelines for ARDS or general ICU mechanical ventilation, they just tell you, well, don't be too worried about the CO2 levels. It doesn't really matter. The important is that the pH is preserved. But in brain-injured patients, it's not something that we can completely apply because, of course, CO2 values importantly influence brain hemodynamics, and sometimes we have to manipulate the CO2 to obtain good values of intracranial pressure. So it is a physiological problem, and in fact, if you look at previous data, there were a number of what I call false beliefs regarding the mechanical ventilation in brain-injured patients. For instance, the use of very, very low PEEP or zero of PEEP was quite common. Tidal volume were very, very high. But probably it's also because of this reason that the incidence of ARDS was so high in the past. But at the same time, it's also true that sometimes the brain and lung go into different directions for the CO2, for the targets, but also for the target targets of oxygenation. I don't think any neurointensivist would allow a 55 of PaO2 in a brain-injured patient. Elisa has discussed this before. And I think we will all be reluctant in using prone position, recruitment maneuver, etc. At least we will think twice. So, what to do? We don't really know because the evidence are very low. This is a pre-planned sub-analysis of TTM studies, so we are about more than 2,000 patients, pre-planned, so there were very granular data, very good data, and what we did here was to assess all the ventilatory settings and evaluate the association with the outcome. Mortality was associated with some of the ventilatory settings, in particular some of these settings, so respiratory rate, driving pressure, mechanical power, and ventilatory ratio. So in one word, these are sort of the composite parameters. Driving pressure is plateau minus the PEEP, mechanical power takes in consideration the PEEP, the tidal volume, the respiratory rate. So the concept, the key message from this paper, in my opinion, is that we need to manage all the different ventilatory settings in order to avoid too much work to the lung. And one of putting together all these, the strongest effect was basically obtained with this formula, which is a formula that is based on the driving pressure and on the respiratory rate, with this kind of relationship between the two of them. But apart from this, that was a pre-planned sub-analysis, we only have data regarding retrospective studies, few randomized control trial. But what do people do in real life? Edoardo Piccetti a few years ago did this survey and started to notice that things were starting to change in terms of practice of mechanical ventilation. The levels of PEEP and the levels of tidal volume were quite going in the direction of a general ICU population. It seemed like that physicians started not to be too much scared in applying the principle of the general ICU population in brain-injured patients. And if you see, in fact, the trend over time, you will see these are three cohorts, 2004, 2010, 2016. This is a very big study from a Spanish group. And the interesting thing is that in 2004, these are the values of tidal volume. The median value of tidal volume was 9, but 30% nearly of the patients had a tidal volume higher than 10, 12 milliliter per kilo of predicted body weight. This is in a trend in reduction with 2016 7.9. We have now the data of 2024 that I showed you in a second. Same thing for the PEEP. If you think that in 2004 1/3 of the patients were ventilated with ZIP, this explains to me the incidence of pulmonary complications, to be honest. It's because we have improved, we have learned. In 2020, so before all the studies and the sub-analysis and post-hoc analysis, we put down a group to write the guidelines for mechanical ventilation in acute brain-injured patients. The problem of these guidelines is that are based on very, very, very low level of evidence or no evidence at all. We try to discuss all the part of mechanical ventilation, but despite there was a very low level of evidence, the agreement among the experts and our brain neurointensivists and also general intensivists is that in any case the general principle of lung protective ventilation should be used even in brain injured patients. But which are these parameters? What is more important is still not completely clear. The PEEP, for instance, is an important point because I think that we obtain a weak but anyway an agreement regarding the fact that the PEEP, if it is set in a physiological, a precise way, is not a big problem for the brain, and that for sure what we need to do is to stop ventilating patients with zero of PEEP. This will only cause consequences. And looking at physiological study, I would like to remind Paolo Pelosi was my boss, and with whom we did this very nice physiological study. We used the quantitative CT for the lung to assess the effect of recruitment on the lung and at the same time the changes of intracranial pressure. And this study, which was done with the segmentation, the manual segmentation of each CT, has told me a lot, because the ICP starts to increase only when the increase of the PEEP causes or an increase in CO2 or a reduction in the recruitment with increase in the parts that are hyperventilated, or when cause an hemodynamic instability. So I think that from a physiological perspective, this means that as neurointensivists, we need to be even more precise than the general ICU physician in setting the PEEPs, because all these parameters must be 100% met if you don't want to have a cerebral effect. And this is what I think has demonstrated this randomized trial, very nice study where basically patients were randomized in tidal volume, high, low tidal volume, and 0 and 12 of PEEP. And as you can see, this is an example of monitoring. This is the ICP monitoring. This is the PRX, the RAP, and the tidal of CO2. As you can see here, what happens is that there is a quick drop, a quick reduction of the tidal volume, and here, quick increase of the PEEP. The concept is that one size does not fit all. In this case, as you can see, there is often an increase of the intracranial pressure. But to be honest, I'm not surprised, because the design of the study was not individualized for the patient's need. It was just 0 or 10. We said we had no evidence. With Fabio Taccone, Paolo Pelosi, and Giuseppe Citerio, many years ago, we planned a study. This is the Venti-Brain study, which has been published a couple of weeks ago. It was a multi-center study, which included 74 ICUs and 26 countries, where adult patients were admitted and evaluated who required mechanical ventilation, and data about mechanical ventilation were taken every day for the first week, and then at day 10 and day 14. We enrolled more than 2,000 patients. These are sort of a characteristic of the study. We are planning to do a number of sub-analyses. As you can see, for instance, 61% from high-income countries. It means that a huge amount of low-income countries participated in these studies. And these are the results. And here are the 2025 median values of the different settings that are used in the neurocritical care population. These are over the days of the data collection. Tidal volume, median tidal volume was 480 milliliters, and per predicted body weight was 6.5. So very, very protective, in my opinion, quite low. Considering also that these patients were patients with healthy lungs, because the compliance was generally good, and the incidence of ARDS in this population was about 3%, so very, very low. PEEP 5, VO2 40, peak plateau pressure 15. Again, very, very protective. And the same for what concerns the driving pressure and the mechanical power. What surprised me a bit regarding this data is that this is the same graph as before, but with a difference. Here you see the different parameters in the presence or not in the presence of intracranial hypertension. And we found no difference in the ventilatory settings regardless the values of intracranial pressure. We don't know why. Probably clinicians tend to use other methods rather than the ventilatory settings to reduce ICP. Probably they don't use too much the hyperventilation, the modulation of the CO2, but the message is that even when there is intracranial hypertension, the clinician tends to keep using lung protective ventilation strategies. Heterogeneity among countries, very, very high. I was not surprised instead about this. There is still a huge heterogeneity, especially for some parameters like the driving pressure or the mechanical power. Less heterogeneity for what concerns plateau pressure and tidal volume, probably because there are more evidence about this. And finally, the effect on mortality. We found a strong, significant association, even after adjustment for different cofactors, regarding P-peak, P-plateau, driving pressure, and tidal volume for predicted body weight. No effect on 6 months neurological outcome, and here we open another important door regarding research in general. So, my take-home message are basically this one. I think that what we have learned is that we need to apply the same principle in brain-injured patients and in non-brain-injured patients initially. But we also have to keep in mind that here is the staircase approach for ICP management. Here is the staircase approach for ARDS. So the problem is when you have a combination of two, ARDS and increased ICP. And these two staircases become a much more complex figure where you have to consider every tier for ICP and the different strategies according to mild, moderate, severe ARDS, and you might have to skip some of the staircase that you generally use for the brain or for the lung. Thank you for your attention.
Chiara, thank you very much for that excellent talk. Are there questions from the audience? So, congratulations on the VentiBrain study. I don't see any. Can you show hands if you have a question?
Oh, there's one at the back.
Yeah, up there. In the last row.
At the back. At the back.
In the back.
No.
Can I go?
Maybe.
Yeah.
Well, there's one here at the front.
Congratulations, Chiara, for the presentation and for the VentiBrain study. Just a quick question. If you had to think about the design of a randomized controlled trial based on your large observational data, what would it be?
So I think that now we have a good observational evidence. We have a randomized controlled trial from Luciana Mascia. I think what we should do is to try to replicate the studies and the trials of the Provenet now that we know a bit more about physiology and non-physiology. What I have learned, and so on what I will not do a randomized control trial, is that to me the tidal volume is really not the target of my mechanical ventilation protection. If you have seen the results, I was expecting a question on this. Tidal volume was associated with mortality, but in an opposite way compared to the plateau pressure. My feeling, what I think is that the protection is given by driving pressure, plateau pressure, etc. But as long as you are protected with the pressure, the tidal volume doesn't need to be too low, especially in brain-injured patients where maybe you need a higher tidal volume to control the CO2. So I think we have enough evidence for plateau pressure. I don't need the trial on tidal volume. Probably I will go for PEEP if I had to choose.
There's time for one more quick question.
Would you recommend a specific PCO2 target in those patients developing vasospasm after TBI or after subarachnoid hemorrhage?
I don't see you, but I hear you.
Here, I'm just here. On the other side.
Hi. So we are conducting now a sub-analysis on CO2, specifically on CO2 with a database of VentiBrain. I don't have yet the results, but I can tell you what we have learned from the ENIO database. In the ENIO database, we looked at the CO2 values. It was a paper that was published last year on intensive care medicine. And the U-shaped curve in traumatic brain injury had as lower and upper threshold 32 and 45 millimeters of mercury. My take-home message is that reflects the Seattle guidelines. So a mild hyperventilation, so 32, 35, still was not associated with a worse outcome. But when we did the sub-analysis according to the presence of different type of brain injury, so subarachnoidal hemorrhage patients, this curve was definitely shifted on the right. I think it is because exactly what you were mentioning, these are patients where there is a risk of vasospasm, you need to give perfusion, probably hyperventilation in these patients might be more detrimental.
Very good. Thank you very much. All right, we're running a little bit behind time, but it's from the lungs to the heart, and our next speaker is Katharina Busl, who comes to us from Florida in the United States. Katharina.
Thank you so much. So we'll talk about not necessarily how traumatic brain injury affects cardiac function, but how it may affect cardiac function. I have no disclosures that are particularly relevant for this talk. So as objectives, I'm going to review briefly what it is the anatomical structural correlate for the brain-heart axis. We'll talk about possible manifestations of neurocardiogenic dysfunction. We will also take into account the role of pre-existing heart disease, review iatrogenic and concomitant factors that may play a role, and then particularly briefly talk about paroxysmal sympathetic hyperactivity, as this is oftentimes a clinical challenge, including monitoring and management. So when we talk about the brain-heart axis, what we do know is certain structural places in the brain, including the hypothalamus, as you can see in the first picture, in the cingulate gyrus, as well as the insula, which is at the border of frontal, parietal, and temporal lobe in the operculum, and then the amygdala deep down, are all involved in forebrain networks that have a role in autonomic nervous control. So when any of those places, either alone or in a combination, is affected through traumatic brain injury, you might see some form of cardiac dysfunction. These are all CT scans of patients that had profound paroxysmal sympathetic hyperactivity, which is oftentimes the more pronounced manifestation that is detected in clinical courses. But as you can see, they're all full with intracranial pressure, midline shift, and so arguably there is an effect on hypothalamus, on amygdala, on the cingulate gyrus, and in many instances also on the insula. So what do we see when we see neurocardiogenic findings? So the pathophysiology underlying all of this is believed to be an initial catecholamine overload that is triggered by hypothalamic stimulation. And then this catecholaminergic overload might lead to direct catecholaminergic toxicity. Not only the absolute catecholamine amount, though, plays a role, it is also creating a sympathetic-parasympathetic imbalance. Types of dysfunction that we might see is autonomic dysfunction with lability. You can see conduction abnormalities and arrhythmias. We might see cardiomyopathies, and we might see myocyte damage. And then, of course, we'll have to take into account also how this interplays with the peripheral autonomic nervous system, particularly if there's concomitant injury such as spinal cord injury, particularly in the cervical range. What are factors for cardiac dysfunction after TBI? So this graphic is from a nice recent review paper from Fabio Tacconi's group that looked at the early neurocardiogenic dysfunctions in traumatic brain injury. So in addition to this catecholamine toxicity or adrenergic storm, TBI and in general acute brain injury triggers a cytokine release and an inflammatory systemic reaction. Then there is the pre-existing condition, and then there is also iatrogenic myocardial injury. Additionally, there might be concomitant injuries, as I mentioned already, and factors that evolve along the ICU course. Now, let's talk about EKG abnormalities. So EKG abnormalities are quite common, estimated to occur in 20 to 54%, in some observational series even up to 88% after traumatic brain injury. Most common are repolarization and conduction findings, such as prolonged QTC, T-wave inversions, or ST changes. The image I have up is an EKG with classic cerebral T-waves with T-wave inversions in all precordial leads. You might see all kinds of arrhythmias. Most common are tachyarrhythmias. Bradyarrhythmias might be there, but you might also encounter new onset atrial fibrillation. Importantly, those findings often occur early during the course and might later resolve, and the hope is that they are purely transient. Myocardial injury overall is estimated to occur in about 15%, evidenced as increased circulating troponin levels. However, the more severe the traumatic brain injury, the more common you will find elevated troponin levels and also the magnitude of elevated troponin levels. Up to 1 in 3 in moderate to severe TBI, and then even up to 1 in 2 patients in isolated severe TBI. And importantly, this is associated with a higher risk of mortality. When we look at left ventricular dysfunction, the disclaimer here is that left ventricular dysfunction has really best been described in the setting of subarachnoid hemorrhage and ischemic stroke. For TBI, the knowledge on risk factors, prevalence, course, and impact are by far not as well studied. And in fact, we published a series on pure subdural hematomas that had all some degree of midline shift. And in none did we find pronounced left ventricular dysfunction to reach the degree of what is commonly referred to as Takotsubo cardiomyopathy. So overall, the estimate is that you might find some form of left ventricular dysfunction in 10 to 20%, higher in older patients. There's a wide spectrum from asymptomatic to mild to quite severe. The course follows the course of catecholamine toxicity. So the initial catecholamine surge happens at ictus, and you will see early hypertension and tachycardia independent of if you have a developing left ventricular dysfunction. And then when the catecholamines drop off and this intrinsic pressing and inotropic mechanism goes away, the blood pressure may drop, leaving for the left ventricular impaired function to come out, and then over the first few days, you might encounter a scenario where all of a sudden your patient might become pressor dependent, and this might create the need for additional workup, ruling out other issues that might be encountered in the setting of your multi-trauma. The impact here also is that this is, if found, an independent risk factor for in-hospital mortality. Now, this is a case, just to illustrate a case that I had recently in our ICU. So this was a 62-year-old male who suffered through the explosion of his chemical laboratory. And he, among having a severe concussion and some broken ribs, as well as inhalation injury and needed the mechanical ventilation and some contusions, he had a traumatic right ICA dissection. You can see in the first CT scan with contrast and CT angio that the perfusion of the right hemisphere, the vascularization is comparatively less than to the left. His initial EKG showed some minor changes, particularly in the repolarization phase. He had a quite significant troponin elevation up to the high thousands, and so he was initially treated as if this was a non-ST elevation MI. However, as the case evolved, so did his EKG. So EKG on day 3 now showed classic cerebral T waves, and concomitantly, the MRI of the brain that was obtained at that time showed a patchy evolving right MCA stroke that he suffered as a consequence of the traumatic ICA dissection. Troponins drop off quickly in the setting of this to be neurocardiogenic. The curve is different with high at onset and then much faster lower than if this was ischemic heart disease. Here is this gentleman's echo, and he did have apical hypokinesis with a poor EF of 30%. Now, what we do not know is what his baseline is, because he never had an echo in our system before, but this was quite pronounced and follows the classical distribution of apical ballooning that is classically described for neurocardiogenic left ventricular dysfunction. Now, what about the role of pre-existing heart disease? So this is super important, particularly as TBI is rising steeply in the aging population. And in the aging population, the prevalence of underlying, perhaps undiagnosed, perhaps known heart disease is, or cardiovascular disease in general is obviously prevalent. So not only hypertension rises from 1 in 3 or 1 in 4 to 3 out of 4 when you think of the over 80 years old population. Coronary artery disease is much higher. Heart failure is much more prevalent, and so is atrial fibrillation and other arrhythmias. What are iatrogenic factors that may play a role? So in trauma patients in general, there might be aggressive resuscitation with IV fluids, creating at least initially a quite brisk and rapidly evolving hypervolemic state, which might challenge heart function. Additionally, salt load through the use of hyperosmolar therapy to combat elevated intracranial pressure or cerebral edema might charge the heart. Vasopressor use, whether to support cerebral perfusion or to support systemic perfusion in the setting of shock, both pose an additional challenge if neurocardiogenic function or intrinsic cardiogenic dysfunction is present. And then medication-related, there are some important considerations. Anti-seizure medication is frequently used as prophylaxis within the first 7 days, according to some of the existing guidelines. If you have arrhythmias or you're battling hypotension, it might be advisable to stay off of sodium channel blockers, including lacosamide, which can quite pronouncedly induce arrhythmias. It does induce PR prolongation, so you want to make sure you do not have a heart block before using lacosamide. And then phenytoin is known as a strong sodium channel blocker to have all kinds of cardiotoxic side effects, including hypotension and arrhythmias. So watching out for hypovolemic state and the proneness to arrhythmias in the setting of what you are targeting to hope to alleviate some of the downstream effects of the traumatic brain injury might systemically actually exacerbate cardiac function. Cardiac injury as part of clinical presentation, and of course the course of hospitalization may also play a role. So there can be direct cardiac contusion, thoracic injuries. You might deal with cardiac dysfunction as consequence of hemorrhagic shock or stress during septic shock. And then the systemic inflammatory response that I mentioned earlier that is triggered through the sheer presence of acute brain injury, but also might be triggered by the presence of septic shock and other issues, may lead to additional multi-organ dysregulation, challenging cardiac function. So again, to balance this and think about the time course of the high sympathetic output and this catecholamine surge, while most at ictus, it can last up to 10 days. It will lead to an increase in cardiac afterload and increased myocardial oxygen demand and potentially lead to myocardial ischemia, particularly if other parts are inhibited. It might lead to ventricular dysfunction and also challenge ventilatory practices through pulmonary edema. Now, let's briefly talk about paroxysmal sympathetic hyperactivity. That is a little bit different than the classic neurocardiogenic dysfunction that happens early during the course. It is a transient increases in sympathetic and motor activity. Symptoms and signs include tachycardia, hypertension, tachypnea, diaphoresis, dystonic posturing, hypothermia, flushing, pupillary dilatation, as well as agitation. And those do occur at a frequency and duration of about 6 times a day for about 30 minutes, come on, sometimes unprompted, come off, sometimes untreated. They may, however, be triggered by things such as a full bladder, pain, or discomfort in positioning. The time course for this to evolve is mostly during weeks 1 to 2. So again, week 1 is characterized by this immediate neurocardiogenic dysfunction and paroxysmal sympathetic hyperactivity. Usually there might be a brief hiatus and then it comes after about a week. Might take longer, might come a little bit earlier. Risk factors, particularly for developing paroxysmal sympathetic hyperactivity, include younger patients, the presence of diffuse axonal injury, the more severe the TBI is, if there is elevated intracranial pressure, and then specifically if there are lesions in midbrain, pons, corpus callosum, or the deep gray. These are all images of patients that did have profound paroxysmal sympathetic hyperactivity, and you can see what they share is evidence of elevated intracranial pressure with midline shift in the first panel, and then post-evacuation in the second and the third. And the third one, the MRI, shows a compressive right PCA stroke. So how, in general, do we monitor? If there is concern that it might be missed, it might be a good practice to get, for sure, EKG and troponin on admission and then go along and see what they do. Based on the catecholamine surge coming early, it is unusual for neurocardiogenic findings to develop during the course unless there is something that prompts a secondary event, such as herniation from worsening. So on admission, if normal, we usually do not repeat those findings. We do get a baseline EKG, a baseline troponin, as well as a baseline echocardiogram, and this might be point of care at the bedside or a formal echo either way, and then repeat as needed, trend as needed. Pupillometry might be very helpful, particularly if early on there's a lot of opioid use and you may have very constricted pupils, and then later on you might find the intermittent dilatory effects even with anisocoria during these events of paroxysmal sympathetic hyperactivity. So having an assessment of pupillary reactivity is sometimes quite helpful. In general, management recommendations include to use beta blockade when you can, because beta blockade has a preventive effect for some of those, as it ties directly to counter the catecholamine problem. The issue is that beta blockers might not be tolerated, particularly if you have a pressure-dependent state or hemodynamic instability in the beginning. They do have a benefit on outcomes after TBI in general. Integrative thinking, know the course of neurocardiogenic findings and how they evolve, and then do short-acting medications. Don't commit these forever because it changes. And then importantly, really align side effect profile of anti-seizure medications, particularly if the anti-seizure medications are chosen by a different team than the intensive care team. For drip, sedative, and systemic considerations, I think it's important to balance pain and sedation, particularly considering the stress versus the risk of early sedation holidays, especially if you're fighting the border of a herniation and you might or might not go for a craniotomy, might not be the time to constantly liberate from sedation and induce stress. And then avoid hypervolemia. For paroxysmal symptomatic hyperactivity, specifically beta blockade are equally great because they're preventive if they're tolerated. Clonidine might be helpful to also combat agitation in general, but again, both come with the downside of hypotension. Gabapentin is fairly well tolerated. It might be needed in high doses that might later on counter your early waking up. So again, very careful here. We often use doses of 1,200 milligrams TID of gabapentin during the acute phase, but then have to be pivot and be ready to pull it off quickly to allow awakening when the acute phase is over. Opioids work best, but come with the downside of all the downsides of opioids. Dexmedetomidine for drips is abortive and preventive and is a potent analgosedative, so might be helpful to counter pain. Propofol improves most features, but comes with the cost of hypotension. And then benzodiazepines are most beneficial if there is hypertonicity present. So in conclusion, cardiac dysfunction after TBI is common. It is often mild. It is likely in most instances multifactorial. There's different components that follow a different time course, including pre-existing cardiac disease, always present, neurocardiogenic impact changes with course of catecholamine toxicity early, PSH at 1 to 2 weeks, and then the iatrogenic effects vary with what you treat at which given time. Management always needs to be dynamic and adjusted to the current state and be including neuro and systemic parts in parallel. And I very much thank you for your attention. Would be happy to answer any questions.
Katharina, thank you. Are there any questions? Oh, there's one up the back there.
Thank you for your great lecture. What beta blockers do you use for PSH?
So for TBI in general, the best data are for propranolol. There is weaknesses in those data too, so we try to do propranolol simply for the fact of kind of protocolizing the approach. However, if we need shorter acting or let alone IV, we do use metoprolol.
Thank you. Well, I'm not seeing any other questions. Just in the interest of time, thank you very much indeed.
We proceed to the next speaker, Geert Meyfroidt from Leuven. He's going to talk about sedation, protective or harmful.
Thank you. Thanks for the introduction. It's been a long afternoon, and it will still be a long afternoon, so I will summarize my lecture already in 3 sentences for those who may fall asleep during the lecture. So first of all, I'm introducing the topic, which is what I'm doing right now. It's a quite complex topic, and there's actually not a lot of good data around. Mainly, most of the data are preclinical. And then second, I will show you some of these data that are mainly preclinical and some inconsistent. And then finally, I will conclude that there's not a lot of good data around, and the data are mainly preclinical. So thank you. I don't have any major disclosure here. I'm a PI of a study on ketamine in traumatic brain injury, for which the study drug is supplied by Pfizer. In the general ICU, we've learned not to sedate patients. So when I was still a resident, it was still the attitude of doing wake me up until it's all over, but we don't do that anymore with our patients because we know that in particular neurological outcomes of these patients might be affected by prolonged sedation. So this might already give us a hint that prolonged sedation is not really beneficial for any patient, in particular for their nervous system. Now, the problem is, I also like a bit of punk rock, so that's hence the Ramones. I want to be sedated is actually true for our patients as well. So because our patients, in particular TBI and neuro patients, have particular indications outside the indications in the general ICU, why we want to sedate them and why we use the sedative actually as a therapeutic agent in these patients. So even while the disadvantages of being sedated, like not being able to evaluate the patients, remain in this group, we still need it. We use it for ICP control. If we have difficult seizures to control, we might have to sedate, and we want to reduce brain metabolism. Maybe if we want to manage temperature, do target temperature management or manage CO2 by mechanical ventilation, we have to sedate the patients. And then paroxysmal sympathetic hyperactivity is also an indication, as Katharina already talked about in the previous slide, that needs sedation. And when it comes to neuroprotection, we don't know if any drug is actually neuroprotective. We don't have a neuroprotective agent. For us, neuroprotection is managing the supply and demand of the brain, and sedation can be a part of that strategy. And that's why sedation is also in the guidelines, is also in the CIBIC guidelines. It's in tier 0, where you do a low-level sedation just to allow for ventilation and prevent agitation. But as you move up to tiers, you increase sedation. Pentobarbital coma is, of course, the most extreme form, and I won't discuss pentobarbital coma in this talk, but we do use sedation to control, or at least to improve, to optimize supply and demand to the injured brain. And when it comes to sedation, there's actually not a lot of consensus in what we do. And in particular, for instance, starting sedation, I think, is what most people do. But in particular, when stopping sedation, for instance, the consensus is difficult to find. And it was nicely illustrated by this, which is actually an addendum to the CIBIC consensus guidelines by Randy Chestnut. It was actually a great idea. By him, he asked all participants of the panel, he presented them with different scenarios and asked them to give a color code like, okay, would you dare to stop sedation in these patients? Are you maybe doubtful, or would you definitely not stop sedation in these patients? Depending on that, they would get a color code. And you can see from the heat maps that the different scenarios, I mean, there's patients who were never treated higher than tier 1, you would probably be comfortable in stopping sedation relatively early, whereas patients who are treated in tier 3, you would wait a bit longer. And waking them up too early can be dangerous, and this is also shown in a small study by Raymond Helbog, the chair here, where he studied mainly subarachnoid patients, but also some TBI and some intracranial hemorrhage patients in spontaneous awakening trials. And the nice thing about the paper is that the benefits as well as the harms were analyzed. And the benefit, of course, of waking a patient up is that you can do a neurological exam and maybe detect new neurological deficits, which was the case in one patient. But there definitely was a lot of harm in doing a spontaneous awakening trial. I mean, half of them did an ICP crisis. Some of them were agitated, lactate pyruvate ratios were lower, and PbTO2, so brain tissue oxygen, would also decrease. So that's where we're probably a bit conservative if we want to wake up our patients, and we tend to be careful because we know that we give the sedation for a reason, and that we're not always sure when would be a good moment to stop. Then when it comes to what we do or the drugs that we use in traumatic brain injury in the case of the Center TBI study, also a bit inconsistent. There are differences. Some of them are local practice, but we tend to use most use sedatives are propofol and midazolam, GABA-acting agents. barbiturates, but they're a different class, are used in 20%. Alpha-2 agonists to a lower degree, and then some other drugs are used as well. So also here, there's heterogeneity in what we do. Now, the question that I've been asked to answer, and of which I already gave you the answer in my introduction, are they actually neuroprotective or neurotoxic? Is it good to be sedated if you have a brain injury or not? Well, actually, the data can go both ways. I mean, for instance, take propofol, GABA-acting agent, has some antioxidant properties and can be anti-inflammatory through very complex pathways, can reduce calcium overload and maybe reduce excitotoxicity, can enhance autophagy. On the other hand, if we give too much of it, we have the propofol infusion syndrome, which is maybe not a brain thing, but a body thing, but it can be very harmful to the patient and even be fatal. Mitochondrial dysfunction and inducing of neuronal apoptosis, so anti-apoptotic but also pro-apoptotic, interfere with neuroregenesis and disrupt neurological signaling. Another GABA-acting agent, midazolam, also here, anti-seizure, anti-inflammatory, anti-apoptotic, can enhance glutamate reuptake, which is a good thing, but also impair neurogenesis, cognitive impairment in the long run. We know this from pediatric studies as well. If you study these children in long-term follow-up, there is prolonged cognitive impairment observed in the inpatient who got midazolam, of course, with a lot of confounders, but still a matter of concern. Can worsen functional recovery in brain injury models, and there's also the potential of interfering with neuronal apoptosis in neonates. Let's go to ketamine. And ketamine is, of course, a drug, as a PI of the brain injury and ketamine study, that interests me a lot, but also a lot of potential good properties, anti-inflammatory, through MDMA blockade might prevent excitotoxicity and calcium overload, enhance synaptic plasticity, reduce apoptosis, has some antidepressant effects. Elon Musk takes it, for instance. I'm not sure if it's a good public, if it's a good thing that you take ketamine. We all see the consequences of that now, but it has some antidepressant effects as well in the long run, and then it can be neurotoxic as well. Through different mechanisms. Now, haven't we all learned that we shouldn't use ketamine in brain injury because there's still an FDA warning against it? Well, this is actually based on very small data, and Fred Zeiler, in 2 very nice reviews, have shown that in patients with elevated intracranial pressure, you can give ketamine provided that you ventilate the patient and give them other sedatives at the same time. But there's a lot of potential mechanism by which this could work. So the NMDA blockade has many effects, excitotoxicity related, calcium influx related, also anti-inflammatory related, and even an impact on vasomotor tone and platelet aggregation. And this is a very nice study that has shown this, how this could work. So if there's energy failure, you see massive glutamate release, you have calcium influx post-synaptic, inducing necrosis and apoptosis, which can be seen also by increased NF-kappa B expression. And in this small study where they looked at cell cultures that were given lipopolysaccharide, so an inflammatory damage, when the cell cultures were given ketamine, especially in the high dose, you can see suppression of the NF-kappa B bands here. We also know that ketamine is probably the only drug that can stop cortical spreading depolarizations, which is something that the GABA-acting agents cannot do. Cortical spreading depolarizations are a sign of suffering of the brain and are a large depolarization that actually spread across the cortex and are associated with bad outcome. And it's ketamine, like in this patient. You see patient on fentanyl and midazolam, where the spreading depolarizations stopped when ketamine was started. And here the same in another patient. And in this review paper, it's actually the only drug that was associated with a lower incidence of spreading depolarizations is ketamine. So we are currently studying ketamine in a randomized study. We plan to include 100 patients. Today we included patient number 69. It's a Belgian study. study, and so we hope that we can finalize the study in about a year and publish the results. And then the final or last drug that I will discuss here is dexmedetomidine. Actually, dexmedetomidine is only used very recently, but we tend to use it in combination with other sedatives in our TBI population as well. There might be some neuroprotective and anti-inflammatory properties associated with it here as well, because it will sort of block this hyperactive brain, reduce glutamate excitotoxicity, can be anti-inflammatory, anti-apoptotic, enhance autophagy, and reduce oxidative stress and neuroinflammation, but also potential impact on memory. Peripheral neurotoxicity is also reported, and there might be, in neonates and in developing brains, we're still not certain whether it's a drug that we should give. We have summarized these data in a recent small review paper that was published in Intensive Care Medicine, where unfortunately Springer forgot to publish the figure, so an erratum will be published soon, but this is the figure actually summarizing what I've told you here about the potential neurotoxic, neuroprotective properties of this drug. But my main message is actually that is this. My main message is that we widely use these drugs in combination with each other, and we actually have no idea what we are doing. So the scientific evidence of what we do with these drugs is very, very low. And the evidence is actually conflicting, because the same compound can be neurotoxic or neuroprotective in different settings. And of course, it can be dose dependent, can be duration dependent, can be dependent on age, on developmental phase. For instance, pediatric or neonatal patients might be more susceptible to it. Maybe it can be condition different. But we do need to start doing the studies. We don't know whether the preclinical data that we have actually apply to humans. There's no large-scale RCTs, and maybe we should start with this, try to make standardized protocols, try to make some consensus on what we're doing, and then vary upon this protocol in the clinical trials that we do, because until now, I think what we do is inconsistent, and maybe we are inconsistent with ourselves, even within the same center. So what do we do? How do we combine? How do we build up? How do we taper back? Those are things that we need consensus on. Long-term data are very important when it comes to this issue. Also something that we lack, and also we have limited data on chronic exposure and functional neurological recovery. And with this, I would like to end my talk.
Thank you very much, especially for staying in time. Are there questions from the audience? Maybe I start with. I don't see any hands. Maybe I start with one question. So we still should use sedatives, very important in our TBI patients. How do you monitor, or what would you recommend how to monitor sedation in our TBI patients?
Yeah, and well, the thing is, in TBI patients or in brain injury patients in general, it's a bit different than in the general ICU. I mean, general ICU population, you just want them as light as possible to allow for your therapy. In the TBI patient, you use metabolic suppression as a therapy, and I think there's only one good way to monitor that is doing EEGs. Of course, not everybody has them. And that you will have to rely on clinical scales, but that is, I think, the first thing. Secondly, if you use them to suppress metabolism and to optimize perfusion and consumption, what you should probably, or what could help measuring is brain tissue oxygen monitoring, because you might detect a mismatch in perfusion and consumption that way. So there's not a single answer to that. And also maybe a third thing, if something I teach my residents, but sometimes my resident is in the doctor office, and then the nurse comes in, she says, the patient has intracranial hypertension. Our ICP went up to 22, 23, what should I do? And then the resident from his computer says, give mannitol. And I'm like, what are you doing? You should go to the bedside. Maybe this patient is not sedated. I mean, maybe the ventilation is inadequate. So go to the bedside, examine the patient, and see if sedation is adequate, if the patient is not coughing, waking up, having increased muscle tension. So those very simple things, I think, are important that we teach and continue to teach to our clinicians.
There's one question up there.
Markus Krivars, Helsinki, Finland. Thank you.
Hi.
Very, very nice talk. So regarding dexmedetomidine, I think if you still read the pharmacy text about it, it actually states that cerebrovascular conditions are a contraindication to give them. And still they are used quite a lot, just as you say, as an adjunct to propofol. But then there's the SPICE-3 study, compared dexmedetomidine to other modes of not including brain injury patients, but in the younger patient group there was a trend towards worsened outcome, and of course our TBI patients are commonly young patients. So I must say I'm a bit uncomfortable with using dexmedetomidine because of this, because of kind of signs of potential harm, and without any studies suggesting that it's useful apart from the experimental studies. So how do you see this?
Well, there are some limited small studies, and I can give you the reference afterwards because I don't have it out of my head, but I do have on my computer a couple of references that have studied, I mean, small trials that have actually shown that it can be used safely in TBI patients. The problem with our sedatives is that none of them come without side effects. You can tell the same story about propofol, about midazolam, about dexmedetomidine, and so maybe we should use combinations to avoid toxicity of one compound. So maybe the fact that we combine them allows them to stay below what is a toxic. I don't have any data to support it, but my hypothesis is how I think about it. That's why I think in combination with propofol or midazolam, using dexmedetomidine, if you can reduce the other two compounds a bit, maybe on average you can try to avoid the toxicity of any of them. So that is in general how I think of it, and that's why I'm comfortable with using it. There's actually two phases of sedation in the TBI patient. The one phase is the acute phase with the elevated ICP and where you want deep sedation. But the other phase is when they wake up. And sometimes when they wake up, especially young TBI patients, can be very agitated. And it can be a nuisance and they have to resedate it and then waken up again. And then maybe the ICP monitor is already out, but they try to get out of their beds. And that's also a phase where we use dexmedetomidine, not in a high dose, but in a low dose, just to reduce agitation and just to keep them manageable for the nurses. And in our experience, that works quite well and is quite safe to do.
Excuse me, I have one more question about the place for volatile anesthesia, sedation in neurocritical care. Here. Volatile sedation.
In brain injury, we tend not to use them because of cerebrovascular effects. Well, especially when there's risk of elevated intracranial pressure. So that's one of the reasons why we prefer not to use volatile anesthetics there. So that's the brief answer to that.
Yeah, we might have to leave it there, but thanks very much for exciting, lots of interest in the topic, and I'm sure there's lots more to talk about. Next speaker is Antoine Roquilly from France, who's going to talk to us about long-term outcomes. Antoine.
Hello everyone, I'm pleased to be here and thank you for the invitation. So I'm an intensivist working in Nantes University Hospital, and you will see that a lot of studies and a lot of medical decisions can be done based on translational studies, experimental design, and very nice information, just like what has been shown in the previous presentations on sedations. But we also have in randomized clinical trials in neuro-ICU patients very large studies providing very strong assessment of the efficacy or tolerance of interventions to treat traumatic brain injury patients. And today I have roughly 10 minutes to show you that perhaps we are not looking at the good things, because most of the time we are taking Glasgow outcome scale extended as the primary outcomes. Sorry, the good one. Yep. So why are we using Glasgow Outcome Scale Extended as a gold standard, we are using it in two different situations. The first one is for neuroprognostications. Basically, we want to give rapid information to relatives on the possibility for the patients to recover fully or partially. Can help us to take some medical decisions to increase therapies or potentially to withdraw future therapies. It's also used as a primary endpoint in randomized clinical trials to decide if a treatment is efficient or not. And so it's very important because if we fail to demonstrate efficacy, a treatment shouldn't be used. So in these two situations, we used the same Glasgow Outcome Scale extended. And the first thing is basically not all neurointensivists are very familiar with the way you have to quote this score. And it's very central to our way to treat patients. So I think it's very important to know what is the Glasgow Outcome Extended. And basically, it's this 8 question, and you can see that it starts from the survival, then vegetative state, and you can go down up to 8, which is the best outcomes with a full recovery. So basically, you have to rank this 8 question, and now you can have a Glasgow Outcome Scale from 1, bad, to 8, excellent or very good recovery, and patients can be ranged from between 1 to 8. But it's not always that easy, and let's look at this situation. Basically, you are trying to assess the Glasgow Outcome Scale extended for one of the patients, and you have this different question. The first one, yes, the patient is alive, he's not in vegetative state, and so on, but he's not back to work. He's back to work, but he's not back to his normal life. So basically, you have 5 out of 7 questions. So we would say the Glasgow Outcome Scale extended is 7, and now the score is 4. Because basically, as soon as the first question is no, you stop there. So let's imagine the scenario of a patient who is able to stay at home, but not independently. He needs help for the washing, to clothe himself, but he has a full neurocognitive recovery and he can be back to work because he's a scientist, let's say. So his Glasgow Outcome Scale extended is 4, so his unfavorable outcomes. While these patients may have a full neurological recovery. So it's a very significant limit of this Glasgow Outcome Scale extended. Second thing, we are using this because a lot of score for neuroprognostication has been developed. We all know, or most of us know the impact score and some other ones. And here is the recommendations for neuroprognostication in severe traumatic brain injury patients. So you can see that for quality of life or neurocognitive functions, there is absolutely no score that has been validated. Yet it can be very important for our patients. You can see that all the clinical data are not recommended because 1 is not enough. So basically, if you combine, perhaps it's better, but 1 is not enough. You have several scores that can be used, and some of them are proposed to be able to predict functional outcome, which is Glasgow Outcome Scale extended, so the impact score, for instance. So let's say, all right, this is useful because you can score that very quickly upon ICU admission, and now you can predict Glasgow Outcome Scale extended. But if you look at what are these scores really predicting, it's not the functional recovery. So we performed studies where we combined the data from more than 300 patients, follow for 6 months. We have a centralized Glasgow Outcome Extended evaluation in these patients, and we try to better predict this Glasgow Outcome Scale extended. So we define several scores using several bioinformatic pipelines, and we compare to the impact prognostication score. And you can see that the area under the curve is not perfect. It's 0.75, meaning that, it's not that bad. It's like what is expected. Usually, impact score is able to have an accuracy of 0.8 roughly. But the thing is now, if you remove dead patients and you just keep patients survivor to ICU, and you try to predict with these scores, the Glasgow Outcome Scales at 6 months, and you can see the blue lines, the results are very bad. Basically, you are an area under the curve of 0.5, meaning that you are just throwing a coins and betting for face or tails. So basically, these scores are probably very good at predicting survival, but among survivors, the ability for these scores to predict the real neurological outcomes is not so well demonstrated. So it's a very significant limit of this score. And so one of the reasons to use the Glasgow Outcome Scales probably is not as strong as that we thought at the beginning. And we also use this score because we have the feeling that it's a very robust, easy way to score, because when I show you that perhaps you would have mis-scored the patients at 5, 6, but it was 4, you would say, all right, but I can learn, and now I will be able to properly score this Glasgow Outcome Scale Extended. In these studies, the authors tried some scripts and make some simulation, and you can see that when assessors try to rate, so it's dead patients, very good outcomes. You can see that for very good outcomes, so accuracy, the agreement between observer and scores are relatively okay. For bad, it's relatively okay. But for patients which are very interesting in ICU patients, the one who are an average recovery between 4 to 6, you can see that basically the assessors have a very wide evaluation. Some of them are scored 2, some of them are scored 6 or 7. So for patients of interest, let's say the one that can be changed by our medical intervention in the ICU, the Glasgow Outcome Scales is not scored the same even for patients trained. And in this study, they look at the impact of the number of way of the patients has been, of the trainings as perform a test, and you can see that you need basically to score 50 Glasgow Outcome Scale Extended to be an expert. So it's classical for all the medical intervention which are, let's say, complex. After 10, 20 scores or intervention, you are not expert. So you need to do 20, and over time, it takes 6 to 9 months in centers starting to score Glasgow Outcome Scale Extended the patients to master and do not make too many mistakes. And to be honest, in most of the, or in some of the randomized clinical trials published in big journals, in big studies, the way the scores is, the way the Glasgow Outcome Extended is scored is not well described. You never know, or we do not pay any attention to the fact that it's a centralized assessment with an expert, or each center can score the patients. And I think it can have a very significant alteration of the estimation of the intervention effect. So not so easy to score, not so easy to predict, not so easy to be robust. You need to be an expert on this question. Or at least we can imagine and hope that this score is susceptible and will change with what we are doing in ICU. Basically, when you try to test an intervention in ICU, you want to look at the effect of this intervention of the Glasgow Outcome Scale Extended at 6 months. We all do the same first primary outcomes. Look at these 3 studies published in the last decade. The first one was testing erythropoietin in traumatic brain injury patients, no effect on Glasgow Outcome Scale Extended. Second studies, continuous hypertonic saline solutions, no effect. Recent studies on the blood level of transfusions, no effect, no statistically significant effect on the Glasgow Outcome Scale Extended. But now let's look at some other outcomes in these studies. In the first two studies, let's look at the survival. So it's not significant, but almost p-value is 0.6 for the erythropoietin. For continuous hypertonic saline solutions, it's the same. For the blood level of transfusion, if you look at the quality of life assessed by different criteria, it's the same. You have now some statistical differences. It means that in these 3 randomized clinical trials, interventions that can be concluded as not efficient because there is no effect on the primary outcome, which is the Glasgow Outcome Scale Extended, you can see some relatively strong effect on perhaps medically relevant outcomes, survival, quality of life. So these 3 studies, to me, suggest that the Glasgow Outcome Scale Extended is very strong to alter or change by medical intervention in the ICU. And so if you want to assess an in-ICU intervention, perhaps this outcome is not the best one to use. We use this Glasgow Outcome Scale Extended scale because it's supposed to capture the complexity of the patients. And in these studies, we try to look at the correlations between quality of life assessed by the patients and Glasgow Outcome Scale Extended. So it's now a study with close to 400 patients. And you can see here that for patients with a full recovery, Every time you lose one Glasgow Outcome Scale score, the quality of life decreases. But if you are in the gray zone, Glasgow Outcome Scale is between 4 and 6, there is no more correlations between quality of life and Glasgow Outcome Scale Extended. So basically, Glasgow Outcome Scale Extended is very good for patients with a full recovery, but for the other ones, it's not very good to assess their quality of life. So let's look at, let's say, the experts. Some medical teams are experts in rehabilitation in this patient because after ICU discharge, these patients usually do not come back at home. They are taken care of by specialists in rehabilitations. And when you look at their guidelines, there is no, the Glasgow Outcome Scale Extended is never cited. They don't know this score. They are not using this score because they say, all right, these patients, you need to increase his mobility, increase self-awareness, memory, and so on. And so they have some specific intervention for every outcomes and for neurocognitive functions. While for us, with a treatment that can be given in the very first few days, we think that we can improve everything there. So probably, if the specialists in these rehabilitations are not using our score, probably we need to think about it a bit more. So we are starting a second randomized clinical trial to test once more the continuous infusion of hypertonic saline solution. So these studies have been funded by the French government. It's sponsored by the Société Française d'Anesthésie Réanimation. And we revised the protocol by the French associations of patients with traumatic brain injury and relative of patients with traumatic brain injuries. So we asked to these medical associations of patients to look at the protocol and give us feedback regarding what is the best primary outcomes to use in these clinical trials. So we propose a lot of scores: survival, autonomies in daily activities, a Glasgow Outcome Scale, basically quality of life. And you can see here the percentage of approval, of full approval, partial approval, and so on. And you can see here that for the Glasgow Outcome Scales, only 50% of patients or relatives understand this criteria and think that it's a good one. Perhaps it's the best one. No, it's not the best one. If you look at survival, 70% of patients or relatives from patients say that, yes, drugs that can reduce mortality is a good drug. It's a good intervention, independently from neurocognitive function. If you look at daily activity, basically the capacity for the patients to wash themselves, to eat by himself, to clothe himself, and so on, 81% of caregivers and patients say that a treatment that can increase autonomy in daily activities is a good intervention. And if you look to the Glasgow Outcome Scale, once more, what is striking is that more than 30% of the patients do not understand this criteria. You can explain to the family and they don't get it. What does it mean? So basically, the Glasgow Outcome Scale Extended is not so easy to score properly. There are some significant differences in the way you score, but also in inter-country, because in France, perhaps, the way you are going back to work is not the same in the US, because if you have a good health cover, you may stay at home, so your Glasgow Outcome Scale Extended will not be the same while you have exactly the same neurocognitive function. So it's not used in rehabilitation center, so probably it's time for us to move to start really to predict what is really matters for patients and what can be changed by our interventions. And in this way, autonomy in daily life activities and quality of life are probably more interesting than the Glasgow Outcome Scale Extended by itself. Thank you.
Thank you very much for a great talk on an important topic. Are there any questions from the audience? So you nicely have shown that GOSE is maybe not the best score. There are lots of variations. And in your last, in the study, you pointed out what the perception of or what the wish of the patient actually is. And I think that's very important to take into account. In your study, did you ask the patients or the relatives for the perceived outcome, or because outcome, the perception of good outcome changes over time? And there are a lot of studies showing, especially in the chronic phase in survivors, that the perception of what is perceived as good or as acceptable outcome is totally different to what the relatives would communicate in the ICU.
Yeah, it's a very important question. So we ask to patients and relative, and basically the scores were roughly the same, except for memories, for which relatives say that it's a very amnesia, and persisting amnesia is very important outcomes to assess, while for patients it was not the case. And in the studies, on average, patients and relatives are 3 years after their trauma. So it's, let's say, patients and relatives with a long-term or moderate long-term outcomes. So they know what are bad outcomes, let's say, they can see that. But to be honest, for patients able to respond, it's many patients with good outcomes, because the other ones, we can't get them. So that's why it was important to us to also question relatives.
Any other questions? I see hands over there.
I have a question. Do you see any, so neurocognitive outcomes and quality of life outcomes are, of course, fantastic. It's been discussed for many, many years. Do you see any challenges in taking into account baseline neurocognitive function and baseline quality of life? Because there's probably a larger degree of variability there, and often, at least in the acute setting, it's not that easy to assess that baseline function.
Yeah, it's a very important point. So with the Glasgow Outcome Scale Extended, all the studies are, let's say, adapt to the impact score and risk and baseline. But for quality of life and autonomy and neurocognitive function, for sure, we will need to have to take into consideration these criteria, the baseline and neurocognitive functions. So, to the best of my knowledge, there is no study that has been developed or published yet to test this, but it's definitely a fascinating part of the future of the research on this critical question of the outcomes in neuro-ICU studies.
We have time for one more question, then we have to proceed.
Yeah, thank you for the talk. I was wondering, so there are obvious limitations to the GOES score, but in your opinion, what would then be a better option, to have a new test that encompasses all these other factors, or to stick to different tests, because that would increase the time that the clinician would have to spend on one patient examining them?
So in my opinion, it has to be more to choose the test adapt to the interventions. For instance, how can we expect and use the same criteria for decompressive craniectomy than for my studies in continuous hypertonic solutions? So the first thing, we can see that there is a balance between the cost, the tolerance for the treatment, but also what is difficult in your question is we can imagine, just like for sedation, that perhaps some drugs are very good for memories and amnesia, while another one is better for motricity. And that's why translational research are very important on that. If you think that you can increase just amnesia and reduce the duration of anterograde amnesia, you should use this criteria because it's relevant for patients. If your treatment is more related to, let's say, diffuse brain damages, perhaps autonomy is the best one. So you have to, in my opinion, adapt to your interventions, and we should not use all the same, always the same outcomes.
Okay, so thank you very much.
Thank you.
And we proceed to the next speaker, Alexis Turgeon from Québec in Canada. He's going to talk about statins, role of statins in TBI. Please.
Thank you, Ramon. So it's going to be like Geert, as he said, three sentences. So thanks, Fabio, and thanks the organizing committee for inviting me here. It's always a pleasure to be at this great meeting. I'm gonna talk about a drug that is used off-label. Okay, I do not have any conflict with this specific intervention. I'm funded through public funds in Canada. So, statins are about 50 years old. The first one that was for clinical use was lovastatin in 1987, but the one that was really, let's say, started to be used very commonly is simvastatin in 88. Why? Because of the FOREST trial. The FOREST, the WASCOP trial, and the CARE trial, these three trials showed increased survival with the use of statins, simvastatin, and Pravachol in patients with coronary artery disease. So it completely changed the landscape of of this disease at the time, and then it became the most, or one of the most prescribed drugs, and still is. In probably most high-income countries, it's in the first 10 drugs that are prescribed for good and bad reason. How does it work? I mean, statins are inhibitors of HMG-CoA reductase, so which basically decrease the amount of mevalonic acid that we'll have in a body that can be used by the liver and can generate cholesterol. So the aim is to decrease the LDL, as you know. There's two types of statins, those that are hydrophilic, others that are lipophilic. The one that we use most often now are the lipophilic one. Atorvastatin and simvastatin are probably still the ones that we see much more at the bedside. And the lipophilic drugs are the ones that are more likely to cross the blood-brain barrier and will have a faster and broader diffusion across cell membranes. They're also the ones that may have more adverse events. So this drug kind of changed practice in cardiology, and then there's been an interest of looking at other patient population that also have vascular disease. So that's how things started in some ways with CNS condition. So these two landmark systematic reviews and meta-analysis were published a few months apart in Stroke and JAMA, showing decreased risk of stroke with the use of statins. So they use all the trials that looked at MI and mortality in patients with coronary artery disease, showed the decreased risk of stroke when none of these trials taken solely has shown any benefit. So it again was a new disease where a drug was to be useful. And then others looked in a different way. That's a nested case study with UK data that showed decreased risk of dementia. So these two diseases or healthcare conditions that are neurologic are not TBI, for sure. They're different. They're more vascular. For sure, stroke is really vascular. Dementia here is probably vascular dementia to more microvascularization. But we might think that there can be something else with the use of statins. So there's been several preclinical studies in the last 20 years and 30 years, but in the last 20 years looking at what kind of mechanism could potentially make that the brain could benefit from statins. So there is mechanism related to the blood flow with decreased microthrombi, platelet activation, but also improve endothelial integrity and ENOS. Decreased neuroinflammation with an improvement of the blood-brain barrier integrity, and for sure decreased cytokines. As for several other interventions, there's an effect here. In the subacute phase of care, it's more related to apoptosis that is theoretically decreased, and in the chronic phase of care, it's increased angiogenesis and plasticity. So these are all from preclinical trials. Some are from clinical trial, like this small single-center trial, 40 patients in acute, moderate, severe TBI in the first 24 hours of their injury, showing a decrease. So rosuvastatin versus placebo, 19 patients, 17 patients. That had outcome data, decreased TNF-alpha, IL-1, IL-6, IL-10 at 3 days. So it's a surrogate. It's nothing that is really solid as an outcome, but it shows some interesting findings. And here, a similar type of trial, 60 patients, acute, moderate, severe, with contusion that were less than 30 mil. Decrease CRP, decrease ESR, and decrease white blood cells at 10 days and 14 days with the use of atorvastatin as compared to control. So there's a few of these studies out there that kind of show that it's not only in the preclinical world that statins may potentially have a role in TBI. And there's this interesting study that looked at trying to look if there is a gene expression and protein expression related to statins that could potentially explain part of the mechanism of statins. So using different databases that looked at protein and gene expressions and diseases, and two different type of network analysis, the MCOD and the more classical network analysis, which is like looking at an association with gene expression for the disease and gene expression or protein expression for the intervention. So they identified 9 potential protein genes that interacted with statins, with which statins could either inhibit or activate, in a sense that it could theoretically improve some markers of disease severity or secondary cerebral injury. So suffice to say that there's been a lot of interest for statins. This is a large retrospective study using data from Medicare, which is the elderly coverage system in the United States, 65 years old, plus patients with TBI, 5 years, 100,000 patients. Half of them had statins before their traumatic brain injury. So this study looked at the effect of those on statins when they have a TBI, whether they have a different outcome. So they looked at mortality. So Antoine will like it. There was 45,000 patients with statin in the cohort. So they defined the use of statin as current use, recent use, so in the last few months, or prior use anytime in the last year. But most of them were in the category of current use. The two most often used statins were atorvastatin and simvastatin. So looking at unadjusted and adjusted analyses, there was an association with lower mortality at 30-day and 60-day, regardless of the type of statin that was used. And when looking only at those who were not on statin at time of the trauma, but were on statins in the previous months, up to 2 months before the trauma, there was a protective effect, or not a protective effect, an association with the use of statin in the last 2 months and mortality, while beyond 2 months, there was no effect. So if the last dose they used was 3 months ago, there was no association. When the last dose they've used, or when they've stopped taking statin was within the 2 months before their injury, there was an association with mortality. They're not perfect studies, and there might be a reason why some patients might take statins. They might have some different socioeconomical status for sure in the United States, despite it's part of Medicare. Suffice to say that there is a systematic review that looks at all these cohorts, evaluating the use of statin pre-injury. And 7 studies were were eligible in this systematic review, including the one that I presented, that basically is the largest one. That has a lot of the weight on the effect size here, showing an association of the use of statins pre-injury with favoring statin with mortality again. And they've planned a sensitivity analysis when you remove the very large cohort that I presented, the association was still present with mortality with those who were on statin before their trauma. Looking at those who continued to take their statin after the trauma and those who stopped taking the statins, the association was exactly the same. So it seems that the association observed is in relation with the previous use before the trauma. So we did a systematic review with one of my students in the last years, looking at the effect of statin in randomized control trials, statins versus placebo control or other intervention that were not having the same mechanism. We found 7 trials. Most of them were from Iran, 5 from Iran, 2 for Egypt. So it's interesting that there's never been any trial outside of Middle East and North Africa. 20 to 98 patient trial, very small trials, 336 patients total, moderate, severe, 1 trial with severe TBI only, 3 excluded patients that were on statins before their trauma. 4 trials use atorvastatin, 3 simvastatin, and from 2 to 10 days of duration of the use of statin. Small trials often means potential risk of bias for different reasons. So 5 out of 7 trials had a high risk of bias, 1 had an uncertain, and only one was considered as at a low risk of bias in this systematic review. What we observed looking at the GOSE, block your ear, Antoine, there was a risk ratio that was favoring statins with no statistical significance, as you can see, but only 84 patients, with mortality 160 patients, again showing no statistical effect here. So 336 patients in total have been randomized in any trial with statin. Only 85 were randomized in a trial looking at the GOS, and 160 looking at mortality. Subgroups were for sure didn't show any differential effect, which makes sense with what was observed with the summary effect size of the mortality, but at least all the subgroups were going in the same direction, despite for sure the confidence interval that is pretty wide. For Laneste ICU, 6 trials, no difference observed, and only 1 trial looked at hospital Laneste, which was lower with the use of statin, but it's only 1 trial, 60 patients. When we grade the certainty of evidence, so this is the grade evaluation of each of the outcome measures, it's a very low certainty for all of them. So very low, for those who are familiar with grade, means that new research can go on one way or another. So the level of certainty of what we observe is basically very, very minimal. So we did not observe a statistically significant improvement in neurological functional outcome. Trials presented significant risk of bias, and the very low certainty of evidence precludes to draw a firm conclusion here. But with all the data that we've seen, all the preclinical and the small trial, the small clinical data, it looks like it could potentially be a candidate drug for TBI. It's cheap, it's widely available, and there's a long track record of safety, including in the ICU. However, although we cannot exclude that it's a potential good intervention, there's not enough evidence at this stage to initiate statin therapy at the bedside. It's something that we should be studying eventually, considering the fact that we have a limited number of interventions, as you well know, in this field. The cost of an intervention like this one that is not high and easily available, and a potential candidate for an intervention. Thank you.
Thank you very much. Excellent talk. So I think it seems statins come and go, and maybe they come again in the sense of clinical trials. So just concerning a trial, what would be the optimal outcome you would look at, and when? Because if you look at other trials, especially in stroke and dementia, as you pointed out, they are long-year trials. So would that be different if you design a study?
I think the GOSE is still the standard of care, the gold standard for any clinical intervention. So sorry to disagree with you, Antoine, but I agree, though, that we need eventually another outcome measure. The reason why we use the GOSE is because it's the best option we have. Because at some point there's a meaning for the patient, and there's statistical concerns too. it's still the best outcome measure we can have. However, in HeMotion, as well highlighted by Antoine before, we've used secondary outcomes that we felt were very important, such as quality of life, EQ5D, VAS, utility index, FIM, PHQ-9. I think we must consider TMOCA. That is, it's a cognitive assessment scale, Montreal cognitive assessment scale, which is validated in several languages and can be administered over the phone. Because any outcome measure that we will eventually develop needs years of validation, and developing a new outcome measure will need to be done with patients. And it's several iterations. It takes years. Then you validate them. Then you validate your questionnaire in different languages. Then you validate the way you administer the questionnaire. So that's why the GOSC is so much used. It's validated in several languages over the phone. It's not perfect. There's no perfect outcome, but that's the one that I would still use with secondary outcome measures.
Any other question or comment? I think.
Thank you. Very nice talks. For the randomized clinical trial, what would be the duration of the treatment for you? You mean it would be a short-term treatment just in ICU? You would extend the treatment for 6 months? And if efficient, would you need to extend the treatment for lifelong? How do you see that?
It's a good question. So I think, there is several questions in your question, because there's also those who will arrive with statins, whether they keep going on. Some of these small trials consider to exclude them. Then you start a statin, then the decision is whether we keep going after hospital stay. I think it would make sense that as far as we're going to be looking at a 6 months outcome with the way this intervention potentially work, it would make sense to go up to the outcome measure, considering how this intervention works. However, there's limited data in any patient population except the CHD one, the CAD, coronary artery disease one, with long-term use in outcome measures. In all the other neuro population were not. Were in all the clinical studies so far, it was not the use that was prolonged. But this is something that needs to be thought, and we're not there yet.
All right, so thanks again for that excellent talk. And we will proceed to Pierre Bouzat from Grenoble. He's going to talk about early prognostication. Please.
Thank you. Thank you for the introduction. A subtitle of this presentation could have been, is it possible? Because mixing early and prognostication is quite strange, I think. But when I make this talk, I was thinking, when do we need to have early prognostication tools? Probably, despite of being challenging, when you go talking with family at the acute phase, you often have questions regarding the therapeutic intensity level you will have in the ICU, the duration of ICU. And also sometimes, even on day 0, you have to take a huge decision in terms of aggressivity. So when you go to when it comes the question to neurosurgery and specifically the compressive cranectomy, you should have tools to try to predict the outcome of the patient. So there is several questions. Are we talking about severe traumatic brain injury, mild traumatic brain injury, young or old patients, and what do we want to prognose? Is this mortality, neurological outcome, quality of life, we had a lot of questions regarding this talk. So I decided to focus my talk on severe traumatic brain injury and mainly on the prognostication of neurological outcome. So let's start with a clinical case. And this case went to my trauma bay when I was on night shift. So we received a young male. He was 23. He has a ski accident. You are in the French Alps. He falls from a cliff. The GCS in the trauma bay and in the hospital field was 6. The motor score was 4. He had reactive pupils with no asymmetry. Transcranial Doppler shows a low CBF with a diastolic flow velocity of 20 and a PI of 1.5 bilaterally. The NPI was done with pupillometry, and it was 3.5 in each high. The ICP was very high when we put the catheter. It was 30 mm of mercury despite T1 and Tier 2. This is a CT scan. As you can see, there is a subdural hematoma with a midline shift and site of intracranial hypertension on the CT scan. And the question is, do we go to the operating room to evacuate the subdural hematoma and probably make a decompressive craniectomy? And this is day 1. So obviously, we need some tools to guide our decision. So we will have the answer at the end of the talk, just to keep you alive. So you have here the initial, we will go through all these clinical items and imaging as well. So if you, I'm not a big fan of scores, but if you look at the crash score and the impulse score, you have all the predictor, the usual predictor for neurological outcome in this patient and mortality, obviously. You can see I put all the items with the clinical characteristic imaging of the patient, including laboratory data. As you can see that the 2 score were a bit different. The risk of unfavorable outcome at 6 months was pretty high in the crash prognostic tool. And using the impulse score, it was only 1/3 of risk of bad neurological outcome. By the way, if you want to choose one score, I think the impulse score is probably the most reliable, and it has been also revalidated in modern cohorts. As you can see, the impulse score has been tested in terms of calibration and discrimination using the center TBI cohort and the track TBI cohort, and the study found that this score was still reliable after 20 years. So if you go into details, what about the different clinical assessment we have? GCS is obviously one of the most important score we have, but in the GCS, you should stick at the motor score. The motor score is really important because it's not influenced by associated intoxication. Even during a ski accident, you can be intoxicated because you're in the Alps in a huge ski resort with bars. And you can see that if you want to predict clinically significant brain injury, no surgical intervention, emergency tracheal intubation, you can see that the area under the curve of the motor score is relatively good and is similar to the GCS. So motor score is really, I think, an important item to take decision. Obviously, the pupil reactivity is important. We know for years that when you have one pupil reacted or no pupil reactive to light, there is a huge increase in the odds of ratio of bad outcome. And you can see in terms of mortality as well, the increase in mortality when you have both pupils reacting, one non-reacting, and both non-reacting. But this study was done with a pen light, which was the old method to measure pupillar reactivity. Using the crash score as well, you can see the increase in the risk of mortality or unfavorable outcome when you go from both pupil reactive, then you move to only one react to light, and you have non-reactive. You can see the increase of bad outcome and mortality. So right now we have new tools, or quite new tools, it's not very new, but you can measure more accurately the pupillar reactivity to light thanks to automated pupillometry. We had two different devices. One is built in France, Marseille, and the other one in the US from Neuroptics. It's very easy, and when you put the device on the eye of the patient, you will have a curve showing the pupil reactivity to light. You have a latency, constriction velocity, the difference of size between baseline and minimal size, and then you have the dilation velocity. And combining all these parameters using an algorithm of the company, of the Neuroptics company, you also have the NPI, which is the measurement of the patient that is normalized to a standard population, a diverse population. So it's a kind of Z-score, if you know statistics. And if you have NPI higher than 3, the NPI is considered as normal. And when it's lower than 3, the NPI is considered abnormal. NPI had been tested in this important international observational study. It was a multi-site study. You can see that in patients with bad outcome, the proportion of low NPI was higher than patients with good outcome. But if you look into details, there are still patients with bad outcome with sometimes NPI higher than 3. And I agree with Giuseppe, the time course of the NPI is also important. But sometimes at the very early phase, you only have one measurement. And obviously, one measurement is not enough to take appropriate decision. As you can see here, even patients with bad outcome may have appropriate NPI. By the way, you can see that the relationship between the odds ratio of bad neurological outcome and a 10% increase in the frequency, 10% increase in the frequency of NPI lower than 3. And in the model 2, you can see the odds ratio. If you have an NPI lower than 3, you have a 6-fold increase of bad neurological outcome. In a subset of patients from Brussels and Grenoble, we'll look at specifically at the automated pupillometry on admission when the patient arrives in the trauma bay, like we did in our young patient with a ski accident. The GCS was not all severe TBI patients. We also have moderate TBI. 26 deaths, 49 with unfavorable outcome. And you can see that even considering the worst NPI value, there was a trend towards lower NPI in patients with unfavorable outcomes, but you can see there is a huge dispersion of all the points. And only one measurement has a limitation, but you can see that in patients with unfavorable outcome, the NPI tended to be lower. We also look at only severe TBI patients in the Brussels and Grenoble, and we look at automated pupillometry on admission and transcranial Doppler with pulsatility index and diastolic flow velocity. You can see that here is a different tier. We look at the prediction of therapeutic intensity level, so you have the tier 0, 1, 2, 3. You can see that the NPI value decrease with the increase in tier therapy. This was less obvious for pulsatility index and diastolic flow velocity, but you can see an increase of PI on admission to predict associated with a high therapeutic level, therapeutic intensity level, and a low diastolic flow velocity. And what is really important is that the TCD and NPI can rule out the need for neurocritical care. When you have a bad TCD or a low NPI, it's sometimes difficult to predict a high level and high intensity level of therapy. If you go to imaging, This is I rendered the curve of the Rotterdam and the Marshall score. You can see that it's not perfect to predict mortality. And I think we should move on, and we are all keen of artificial intelligence, and we have an ongoing program where we try to make segmentation of CT scan using Atlas. We try to better localize, better describe the brain lesion, and using we develop an algorithm on 30 TBI patients, and we use 12 patients in a validation cohort from the OxyTC trial. And you can see that the volume, the spatial location, and type of brain lesion observed on admission predicted therapeutic intensity level within the first week in ICU. And we try to move on and to go to generated artificial intelligence imaging. Here you have the CT scan on admission, the CT scan on day 1, and you have the CT scan on day 3. And the zone in red are the prediction of the algorithm based on D0 and D1, and the blue area are the actual size of the brain edema. So we try to predict the brain edema on day 3 based on the images on D0 on admission and day 1. So we have also an ongoing research program trying to compare the generated image versus the actual image on CT scan. Just a few words on MRI. We are talking about early prognostication, so I don't think MRI can be very useful at the very early phase. We have many limitations, but the combination of fractional anisotropy and diffusivity is probably the best way to predict the outcome of the patient. We have a recent publication by the Paris group with a validation of 196 patients, and they were able to, in red you can see that the prediction of the algorithm was a bad outcome, and you can see the actual evolution that is really bad. In green you also have patients with a prediction of good outcome, and some patients remain green but others remain red, and in gray you have probably the classifier was not able to define the outcome of the patient, and some patients had good outcome, bad outcome, so this is not perfect. And the main problem is that all these images were made later on, but we have some technological evolution, and now we have portable MRI. It costs around 200,000 euro right now, and maybe this could be the future to make early prediction, but we do have no idea of what kind of images can be made with this type of technology, and what is the relationship with normal MRI. So we go to decompressive connectomy for the patient. We were confident that this patient, because the motor score was high, the TCD was not so bad, pupillometry was not so bad, but at 9 months the patient was bad neurological outcome, minimal conscious state. And I've got another case almost the same with a GCS lower. We made the decompressive connectomy, and the patient was back to study 3 years later. So the picture becomes even more blurred after my talk. So at the end, what do we have? Early prognostication is very challenging, and I show you 2 different cases with 2 different outcomes, almost similar. So there is no perfect tool to guide you for your decision, but associating different tools helps. And the patient is always a mix between green light and red light. So we have to talk to family and interact directly regarding uncertainty, I think. We should be honest. And uncertainty is particularly important in young patients. I think the only exception is all patients with pre-existing comorbidities, with midline shift, large midline shift, and low GCS. Thank you for your attention.
Thank you very much, especially also for the conclusion of, talking about uncertainty in the very early phase with the family. Any questions? Yes.
Thank you. Very nice talk. You mentioned intoxications and the motor score, and I sort of heard that you said that intoxications won't influence the motor score. But surely if you're super drunk or intoxicated, I mean, you could have a motor score 1. You're not likely to have one of 2 or 3 or perhaps 4, but surely you could have one of 1 combined then with your brain injury, which is probably what makes things difficult.
Yes, you're right. The idea is less influence, but obviously it can be influence. But we often see people with correct motor score, but verbal score is very low, high is very low, high score is very low, and sometimes it's when you have an intoxication as well. And I think the motor score is more robust than the high score, the verbal score, and it's more easy to do as well, because it's very easy to do in the pre-hospital field, because you often have only the pre-hospital field in terms of evaluation, because afterward they are sedated and intubated.
Got one more question down the front.
With regards to mentioning using machine learning to interpret early CT scans and patterns, it's super interesting, very hot topic. How do you avoid, because we need a lot of scans, avoiding the confounder of withdrawal of life-sustaining treatment, but still having a sample, because I think that could augment self-fulfilling prophecy in a way with the machine learning. And then
yes,
so
obviously this is only preliminary data. We only have a few patients and we have to confirm the results and to develop all this machine learning. So the story is going on, and then now we try to catch all the CT scans that have been made on admission and then try to enrich the algorithm. We all work a lot on segmentations. It's not so easy. Putting an atlas on the brain is not so easy. After surgery, after some intervention, the structure can move. So this is, you're right, this is very challenging. We need a lot of CT scan to refine our algorithm, for sure. Yeah.
I can see there are a few more questions, but we might have to move on, unfortunately, Pierre. Perhaps address you later. Thank you. Our next speaker is Victoria Metaxa, who comes to us from King's College in London. And Victoria is going to pick up where Pierre, I think, has left off, talking about treatment limitation decisions. Victoria.
Hi, thank you very much. Yes. So, I mean, amazing that you've stayed for 3 hours for me to tell you that despite what you've learned now, you still cannot make a decision right. Well, at least I can't. Don't take it personally. So this is what I'm going to tell you for the next 15 minutes that we can't. I do not have any relevant conflict of interest. So how do we make decisions? We make decisions very differently from one another. So very quickly, let me show you. And that's not TBI related, but this is the truth. So it does depend where you are. So it depends on your geography, right? And this is data from Ethicus 2, which says that if you are in Africa and if you are in Northern Europe, the way you're going to die in ICU is very differently. In Africa, you're going to have about 60-something% death after failed CPR. That percentage is less than 5% in Northern Europe. And you can see all the variation in between. So it depends on where you are. It depends on how rich your country is. Because, and that's from Asia, countries with low middle income have a completely different way of making decisions to withhold and withdraw. So they do less withdrawals of ET tubes, less withdrawals of renal replacement therapy, less withdrawal and less withholding. It also depends on how old you are. And I'm quite old, and you can see this is again data from Ethicus 2 and Ethicus 1, and this is the comparison. You can see that as time goes by, our decisions change, simply because time has gone by. And the decisions to withhold and withdraw have increased, and the decisions to perform CPR that has then failed and the patient has died in ICU has decreased. So we do make these decisions that we all think that we make them based on facts and facts alone, very, very differently. There's great variation in these decisions. Okay, so how should we make these decisions then to limit life-sustaining treatment, especially, and let's make it now, let's make it a bit more specific about brain injury. So nothing is lost yet because we do have guidance, right? About 10 years ago now, the Neurocritical Care Society had this guidance that basically said,
had some recommendations, guidance, that basically says, please don't make any hasty decisions before 72 hours. So, you know, there is a possibility that you might decide to early, don't. In the UK, we've done something similar a few years after that. We basically said the same, but, you know, we're very certain that we do things better in the UK, so we didn't say 72 hours. We said, you know, a little bit, 24 to 48 to 72 hours. So there is guidance out there to tell us how to make these decisions. And then this is what we think we do. This is from the Center TBI, which is a multi-centered, or was a multi-centered trial in about 20 countries, I think in about 68 ICUs. So they collected observational data about how these countries in these ICUs deal with TBI. And before they started collecting this data, they've given them this questionnaire. They've asked them many, many questions. And one of these questions was, hey, at what time do you think you will withdraw treatment if the patient has poor prognostic signs, so a bad CT, for example? And this is what they said. They basically said, that the majority said, more than 2 weeks. I will wait more than 2 weeks. Some of them also said more than 1 week, but look at the top there, almost no one said, or an average 10% said, I will withdraw, I will make the decision to withdraw within the first day. So this is what they said, right? So we know what we're going to do, and we know what we say we're doing. Okay, so what do we really do? Surprise, surprise, none of the above. So I'm going to show you several several observational trials. This is quite recent, from last year. This comes from the Netherlands. 2 level 1 trauma centers, and they looked at when exactly the decisions were made, and the decisions were made 50% less than 72 hours. So in 50% of the decisions to withdraw was done less than 72 hours, and about a third was done in the first day. And this repeats. This is a Canadian study, again, and that's quite old, but you see the results are the same. The same from Norway, the same in our center, we're looking at it right now. And this is very interesting because this is the center TBI. These are the same people that said, we would never withdraw within the first day. And this is what happens. About half of them have the decisions before the 3 days were over, and the median time was 24 hours. So, you know, we think we know what to do, but the decisions are not very easy to make. This is the track TBI, again, a different study, more than 300 patients with severe TBI. Again, the same. This is very interesting because not only the numbers are the same again and again, you can see that, right? Not only we withdraw quicker than the 72 hours we're meant to withdraw, but also here in this 1 in 5 patients basically that had a GCS of 4, let's say, on presentation, went and had a great outcome in the end, which, you know, I think Pierre said we're rubbish at prognosticating as well. Okay, so this is not news, hopefully, to you or anyone else. This conversation about nihilism, neuro-nihilism, a self-fulfilling prophecy, someone said there previously. This has been going on, these conversations, for 10 or 15 years, right? And if you see the titles there, there's a lot about the art of decision-making and the art of neuroprognostication. Keep that in mind for a second. So why is this happening? Why are we so bad, or maybe variable? And I do think variability is not a very good thing at making decisions to limit treatment. Well, basically because this is the mental model, or something like that is the mental model. So we tend to think that the way we decide is we acquire information, we deliberate, we decide. Plain and simple. And there are studies that I didn't show you there. It's not from the neuro field, but it does show that we, when asked, we think that we're purely factual. Yeah, we decide because we've assessed the facts and that is that. It is not as simple as that. Not at all. Because in every step of that 3 stops of acquiring information and deliberating and making a decision, well, prognosticating and making a decision, different factors are at play. And they are factors like, how can you acquire information if, for example, your hospital is so busy and if your colleagues are sick and you don't have time? Or see how heavy the personal factors feature. So, for example, there are personalities, and this has been studied, that are very optimistic, and they will tend to be optimistic, and then decisions are going to be towards the optimistic part of the scale, irrespective of what the facts are. And so are their counterparts. They will see a patient and they will say, oh, they're going to die. And these patient factors and all the other hospital factors, the time factor, hasn't really been studied, and it hasn't been studied because it's not very sexy, is it? It's not ECMO, it's not cannulas, it's very difficult to actually see what's going on. So we don't really have research into how we make decisions. All right, so what can we do? The first thing we can do is maybe stop talking about art. And if we decide and accept that if we continue to talk about art, we somehow justify the variability, justify the subjectivity, and justify the lack of scientific rigor that our decision-making should have, I think would be a very good step. Let's move away from art and just understand that prognostication, but also decision-making, should be presided by some rules and should, at least we try to be based at some subjectivity. What else can we make? What we can do? Well, this is, I tried to collate all the things from various studies you can see that try to study decision-making, and you see we can put them into three categories. First of all, increase our knowledge and expertise. If you've never seen a disease, you will never be able to recognize it and make a proper decision about it. If you've only studied in your own environment, you will perpetuate the decision-making of your environment. So, focus training, detailed feedback, call that, and simulation. Unfortunately, many of the things on this slide may make sense, logically, but they're not backed by robust evidence. So simulation about decision-making would probably make sense, but the evidence yet is not out there. So improve your clinical reasoning and use things like reflective practices to increase your metacognition, which is like my favorite thing, which basically means learn from your own practices, learn from the decisions that you and your department made, and some of them might be, right, spot on, and some of them might not be 100% right. So go back, reflect, see why you've done this, and then the metacognition means you will then be more aware of your own personal biases, and maybe that will help you maybe not make the same mistake. To me, that makes perfect sense. Again, the data out there, or the evidence backing it, is not there. And also, it's not very easy to do, right? You do have to be in an environment that actually promotes healthy feedback, promotes healthy conversations. You'd be, let's say, free to go to a colleague and say, do you know what, you thought this patient was going to die, and they didn't, let's learn about that. Not many departments can do that. And then use decision support tools. Decision support tools, AI, we've heard about this, about prognosticating and making decisions is the future. They're very useful in making decisions in radiology and some pediatric settings. There are a couple of publications about making decisions to limit treatments based on decision support tools and AIs. I'm sure you understand they're inherently, difficult to accept. So they haven't taken off yet. All right, this is an excellent, excellent paper. I do suggest you read this, which basically says, take it in your stride, understand and accept that there is uncertainty. Start talking about uncertainty. I think Pierre said that from the beginning. Talk about uncertainty not only to yourself, to your colleagues, but also to the family. And then as you progress, communicate clearly with the family and ascertain patients' preferences. if you can, because I mean, I can talk another 15 minutes or more about ascertaining patient preferences, but leave that aside. At least try and understand the goals and individualize your plan to the patient you have in front of you. Be aware, and this is the metacognition, be aware of your own heuristics and be aware of your own biases. So the heuristics are the shortcuts, right? 70 years old and an intracranial bleed. I can see a walking stick. My mind immediately, I'm not going to wait for 3 days. The outcome's going to be poor. So these are the shortcuts that we all develop to help us not spend ages in life, but be aware that sometimes they might lead us down the wrong path. And of course, decision-making, just, spread the burden of making a decision, especially about someone you've never met before. So you bring the evidence, bring the family, to bring, the other person into the equation. Depends on where you are about this balance of shared decision-making. There are some countries that, the patient family surrogate will make the decision. There's always this balance, but, at least the patient or the decision needs to be individualized. And I'm going to conclude and I'm going to say that I hope I've convinced you that the way we make decisions is very variable and is hardly ever factual. That there is a great level of uncertainty that sometimes we seem to completely ignore because it makes us feel very uncomfortable. We need to be self-aware that we do this of our own biases, but unfortunately, there is no evidence that knowing what makes you tick, for lack of a better expression, will improve your decision-making. Research is limited, and this is a problem because we do make hundreds of decisions every day, and we don't really know how we make them. And then, watch this space for decision-making aids and, for example, time-limited trials in ICU. And with this, I will thank you, and I'm ready for questions.
Thank you, Victoria. Very clear explanation of a complicated subject. Are there any questions? If not, I have one. Oh, is there one up there?
Good evening. Thank you very much for your talk. Is there any, you've alluded to the paucity of research and data about decision-making per se. Is there any suggestion from the literature that group decision-making or conferring with other colleagues is beneficial, and if is there an optimal number? Because before you get to a panel of 12, for argument's sake, that may be too many.
Yeah, so again, very good question. Thank you very much. Yes and no. So clearly, the fact that the decision should not be made by one person has been discussed in literature for the last at least couple of decades, and I think that's how shared decision-making and interprofessional communication started being at play. There is no number. There are some cognitive aids that basically say, you know how you have a checklist to put a line in or whatever? You should have a checklist to make a decision, and one of these boxes in your checklist should be, have I considered all alternatives? Have people challenged me and told me alternatives? So yes, having other people into the game intuitively would make the decision more robust, but please be aware of your echo chamber. So again, if you work in a very tight department and almost everybody after a few years goes down a certain path, that does not mean that if everybody agrees the decision is the right one. Is that okay?
If there's no other questions for the audience, I have one, and maybe the answer would be quick, it's just not known, but one of your first slides showed really marked differences between countries and regions in the way decisions are made. Is there any evidence that suggests that patients, and probably more relevant, the patients, their relatives, are more or less satisfied with any of those things? Or conversely, do you think that those decisions are made differently in different places to achieve satisfaction of the relatives?
Very, very good question. I'm going to take a step back very quickly and say that patient or family satisfaction is a very flawed measure of our success. Very flawed, is used as a surrogate measure of our success at decision-making, but it's amazing about consistently throughout the world, but the world is only the US and Northern Central Europe, because that's where the data comes from, so the world, patient satisfaction throughout the world or family in the ITU is more than 85% to 90% consistently. And it's higher when patients die. So it's so crude. How do you know? I don't know. Helpful.
Very good. Well, thank you very much.
All right. Let's go.
So thanks for staying here. It's a privilege to introduce the last speaker, Sarah Walsh. She's coming from Seattle, United States, and she's going to talk about prolonged altered consciousness, extubation, or tracheostomy. Please.
Thank you very much. And do I advance the slides with this one? No. How do I? Quick question. Sorry. Just push. Button. Wait, sorry about that. This one. Okay, perfect. Well, thank you so much for still being here, and we'll do our best to get you out at a reasonable time. This is a very commonly encountered and relevant challenge for neurointensivists in patients with disorders of consciousness, including TBI. And I hope to give you an answer, at least have you leaving not being more confused. I have no relevant COI. And so the questions are, we're still struggling to really predict the ability to protect an airway and predict which patients can successfully extubate or the need for tracheostomy. So yeah, questions, who can we safely extubate? And then the timing is a question. When should we make this decision? If, at some point in the middle of prognostic uncertainty while we're ventilating someone, should we just do it early? Are there advantages to that, or is it better to wait? This is actually a mnemonic one of our fellows came up with, or taught me, is, in terms of what you think about predicting successful extubation, you always think about the causes in any critically ill patient, and there's the initial cause, that is often the brain injury itself, but then also additional causes that come up. And then it's not just the initial cause, but you also think, are there any reversible causes, such as, and that plays into the timing. Cerebral edema has a peak window. You think about, is there non-convulsive status epilepticus that you can treat? So there's some neurologic causes. PSH is one, as the hydrocephalus. Those are kind of short-term things that you could make better and could change the game. And then there's the long-term injury, and there's the neuroanatomic impacts of that. For example, patients with infratemporal injury and injury to the brain stem and P fossa have a higher risk of failing extubation, needed tracheostomy. And then there's also cardiopulmonary causes. You assess oxygenation, ventilation, do spontaneous breathing trials, the neurologic examination. And, you think about kind of the, structures that account for airway protection, the reticular activating system, thalamic projections, bicortical projections, and it can be direct injury, but also indirect injury to these structures as you make these decisions. And then as well as the respiratory centers in the mid to lower brainstem. Secretions go hand in hand with the examination, because with the better examination, the less you have to worry about secretions, and then you think about the clinical relevance. Here's a summary about some studies, and again, this has been studied since the early 2000s. It's been 25 years, and we have many answers, but still not a perfect way to do this. Extubation failure often defined as 48 to 72 hours from extubation, sometimes longer. And the rates are kind of between the 15 to 20-ish%. There's one study what's a bit higher, bless you. Two studies, but one was infratemporal injury, where it was 40%, and it was a third in patients where they waited for the whole ICU stay. The results of mixed GCS in some studies was associated with it, but in 3 of the larger prospective studies was actually not associated. And then most studies, there's 3 studies that defined a score. There's a Copeland study, actually back from Seattle, from us, a single center study that was the first that found cough, gag, sputum description and viscosity and the need for suctioning frequency. The study from Latin America, they found that gender, the motor GCS, again, secretions and presence or absence of a cough and duration of mechanical ventilation played into this. And again, those are prospective observational studies. So some of these, if someone's ventilated, there's probably it's a mark of severity. The Visage score also is a multi-center study, not yet validated, but actually had a pretty strong predictive value. Visual pursuit, swallowing attempts, age played a role, GCS also, and score of more than 3 was associated with extubation success. I see Dr. Turan in the room here. The recent meta-analysis where a substantial proportion was TBI. Just looking at the rates of who received a primary tracheostomy, just seeing the variation across studies just shows variation in practice and the uncertainty in this area. And patient that failed extubation had a higher mortality and ICU length of stay, which also makes sense and reflects kind of disease severity. Factors associated with failure of older age, longer duration of mechanical ventilation. And success was, I think, marginally associated with the presence of a cough and swallow. So those are all kind of factors that make sense anatomically and are kind of consistent across studies. The largest study recently on this was the ENO study from 73 ICUs in 18 countries, included a mixed sample of acute brain injury, about half had TBI, excluded patients with spinal cord injury, neuromuscular weakness, those that were died before that were extubated to withdraw life-sustaining treatments and terminal extubations, and those with major respiratory disease at baseline. And the outcome was extubation failure by day 5. And then there were secondary outcomes, just extubation failure overall, duration of ventilation. And then they used a lasso model to derive a predictive score. About 80% an extubation attempt. Out of those that just got a primary tracheostomy, those all had a higher duration of mechanical ventilation, ICU mortality. And that was compared to extubated patients, both success and failure. But again, it's a prospective observational study, so that may have just been a marker, or likely was a marker of disease severity. There was a sub-analysis, again, by Dr. Turan, that showed that extubation to prophylactic non-invasive, which I think happened about a quarter of the patients, was not associated with reintubation. And then failure in general was less likely in TBI compared to the other brain injuries, more common in older patients, low GCS. They actually derived a 20-factor model and a 7-factor model. And I'll just list the 7 factors as TBI, having a gag, cough, swallowing attempts, ET2 suctioning, and the motor GCS. For the 20-factor model, not very practical, and neither of the models had the perfect area under the curve to say, we have a definite answer. And so a failure is complete. A substantial proportion fails is the challenge, but then the majority still does fine. So is it worth trying? And we had actually another interesting study where we looked at markers associated with outcomes. We looked at mechanical power. We looked at kind of different vent parameters and just looking at outcomes, and driving pressure emerged as the one that was strongest associated. We also looked at a surrogate formula for mechanical power. And we mostly looked at mortality, ARDS, but something that was actually interesting is that those values, especially mechanical power early on, was strongly associated with reintubation. Again, ENO was a prospective observational studies. There may have been unmeasured confounders that we didn't adjust for, and so we can't assume causality. But it was interesting, left us wondering, is there anything that we're doing with a ventilator that causes VLE and makes patients potentially more prone to needing reintubation or to, de-recruiting, having pulmonary edema? All these questions, so we need more data. We need, we have a robust kind of, set of variables that go through our head as we extubate, but we still don't have a perfect system. Some things on the horizon is some studies with machine learning, again, looking at neuroimaging correlates in addition to exam findings. I would suspect they'll probably complement imaging. And then there's actually, these are very, case series of, I think, just a couple of patients here and there, but where there's actually systems measuring breathing sounds. And so this is a system where electrodes are taped to the trachea, the chest, and capture breathing sounds. And then the frequency off and the intensity off. And you can see from image A to D, kind of, those look normal and stridor evolves. And so those are supposed to be monitors that kind of can gauge when a patient is starting to fail and may need to have to be intubated to avoid kind of emergent intubations. So yeah, we talked about markers of, predictors of extubation with regards to predicting need for a trach. There's a couple of scores, this trach score that shows some radiographic factors, and then the SET score that was developed for the SET point trials, initial one, also validated in larger Northern American cohorts. There's 2 studies, and again, the span of these studies from 2000 to 2025, so we're still asking the same question, which is telling, but study by Copeland from Seattle, from my hospital at Harborview, actually looked at patients that were extubation ready, and that was defined as they didn't have an ICP crisis, and they had a good RISB and passed their SBT, but they were intubated for neurologic reasons and concerns about airway protection. about 57% of them TBI. And then 3/4 around got extubated within 48 hours of that kind of readiness. There was a lot of variation based on GCS, and about 1/4 remained intubated for longer than that. There was a large span for those patients. They had similar reintubation rates, so there was not much gained by waiting. But there was delayed, the patients that had to delayed extubation, a high rate of pneumonia, a higher rate of ICU lengths of stay, as well as increased cost of care. And there was a recent study, a very large study that looked across 8 centers and found similar. They looked at prompt extubation. So after they passed their first SPT, they were extubated at that same day versus others waited to just get more information. And prompt extubation was associated with more ventilator-free days. That being said, again, sometimes waiting is still getting to know your patients if there's a reversible factor, again, such as they have a new fever that is central or they have PSH that that doesn't mean that you should just take the breathing tube out because of this data. So I think there's some nuance required. But thinking about timing of first tracheostomy, you think about early versus late. And I think in general, the thought process that advantages of early trach is, you decrease your dead space, work of breathing, lots of breathing mechanics, and hope to, by that virtue, improve triggering, vent synchrony, and get a patient off the ventilator, improve mobility, suctioning, and other markers of care, and potentially reduce sedation and delirium, mobilize them, get them out of the ICU sooner. But the downside complications of tracheostomy, there's early ones, such as pneumothorax, bleeding, infection, kind of chronic ones, vocal cord stenosis, and then the innominate fistula. They're very, very rare, but I would say, as someone that performs tracheostomies, when the complications happen, they're usually very bad. And so I think the advantages of doing it later, the main advantage is avoiding the tracheostomy in the first place. Sometimes, in a way, also giving a little time. This tracheostomy is a third critical decision point. After the initial kind of ED visit, the kind of very early ICU stage, it gives you time to get to know your patient, the family, and get a better sense of the trajectory. So that might help you make a slightly better decision before you commit a patient to that path of life-sustaining treatments. And, think about shared decision-making, prognostication. But there can be delayed in cares, especially if you wait for a very long time and extubate over and over again. There's an increased risk of death and pneumonia with repeated extubation, and the course to rehab may get delayed. So when should you, and ideally, if you know someone needs a trach, I would argue then you do it sooner to set the patient on trajectory. But again, we still don't need whether someone does. And there have been several studies, many studies looking at timing of tracheostomy. Usually early trachs defined as within the first week, which is interesting in neurologic patients because often ICPs are elevated and cerebral edema peaks in that time. But in general, studies have shown mixed results. The largest study in a mixed general critical care population did not show differences in outcome following patients about 2 years. But they did find that 37% of the patients randomized to the late group, even though gauged by scores and 2 expert intensivists, no longer needed the trach. So that actually just shows that we're bad at predicting this. And actually 20% were discharged home alive in the meantime. So that's the upside of waiting. There were several. There was a meta-analysis by Victoria Metaxa. It was 3 trials that suggested actually lower mortality. The SET.2 trial, so this is not TBI, this is mixed stroke population, was a recent multi-center randomized control trial that came out, done in Germany and the US. And it was basically 382 patients with mixed types of stroke. And it did meet the outcome, which was neurologic outcome at 6 months. Interestingly, good outcome was quantified as MR 0 to 4, which goes up to wheelchair bound. That was actually done because it was a PCORI-funded study, and they looked at patient-centered outcomes, but didn't meet the primary endpoint. Also didn't meet any of the secondary endpoints, including those things we hypothesized, length of stay, duration of mechanical ventilation, sedation. So it didn't have a huge upside, but again, 22% of the patients randomized to the late group did not need the trach anymore. Adverse events were similar. Again, early was CA 3 to 5, and late was day 10 to 14. And in many ICUs, the reality is that we start having these conversations at the week mark. There's a lot of variability. So what about TBI? Would TBI be different in stroke? And presumably now we have an RCT that suggests that there's not a huge benefit of doing it right away. In TBI, you could argue maybe stimulation from the tube could exacerbate ICP crises. That being said, if you have a patient with ICP concerns, you wouldn't take them down to the OR and trach them anyway, because that could also make it worse. You could also think about PSH, kind of stimulating a young patient that then goes on to have central fevers and episodes of autonomic hyperactivity. Robba did a study based on center TBI sub-analysis and looked at trach patterns. And again, this shows that was a very wide range of trach, between 8 and 50%, and also wide variations in practice in terms of timing of trach. Delayed trach was associated with worse neurologic outcomes, but again, in observational study, it's hard to cite in causality. It may have very well been disease severity and the patients getting delayed trachs having more complications before they were able to get the trach. So, conclusions is, yeah, do we really need to trach someone? Should we try extubating? It is reasonable to try, we're just bad at predicting it. We have a lot of factors such as dinner imaging, the exam, gag, cough, all of these things that kind of correlate. If no major concern, it is often reasonable to try in a very controlled fashion, accounting for other risks such as airway stability. Was it a very difficult airway? Did the patient bite the tongue 10 times and has a very swollen tongue? So, you need to make sure it's safe and then have a safe reintubation plan. And I also often find it helpful to explain to the family. So when we say extubation failure, it implies that we failed, that we did something wrong. And I think just honestly disclosing that there's a risk that the tube may have to go back in is always helpful. Always optimize, address any quickly reversible modifiable factors, diaries, treat the pneumonia, and anything you can kind of make better in the short term. Otherwise, don't necessarily delay, because the data seems to suggest that there's not a lot of benefit in just waiting. But we need more information to really answer this question. And with regards to the timing, when should it be performed? There's no clear, strong benefit, whereas there's been some mixed studies, but the strongest studies don't suggest the benefit of the very early trach, and very early means within a week, so again, super early. And the upside is that you may avoid the trach and its complications, get the patient extubated. But again, more data is needed specifically for TBI. Thank you. Those are my collaborators for the studies we mentioned that we did, and this is our crew from the Harborview Neuro ICU. And with that, I hope you can enjoy your evening.
Thank you very much. Excellent talk, and thanks for staying in time. We have time for questions. So let me ask you one question. Prolonged disorders of consciousness means that we are not talking about early tracheostomy, but delayed. So when is delayed tracheostomy? What is the latest time for you in your clinical practice to discuss about that?
Yeah, it's interesting. In our personal practice, it's kind of at the week mark when we start having these conversations. And I think looking at some studies, looking at practice patterns, it varies very widely. So some ICUs do it within their first week, and it's also sometimes driven by resource utilization of the health insurance system. I would say the majority of studies define late as after a week, and that's not late, really, in terms of the trajectory of improvement at all. But it depends, I think, a lot on resource utilizations, culture, and other practical factors.
Any other questions or thoughts from the audience? If not, then we close sharp in time. Thank you very much. It was a great pleasure to have you here the whole afternoon. Thanks for staying for such a long time here. I hope you enjoyed the session as we did. We learned a lot. Enjoy the evening. Enjoy EasyChem 2025. Thank you very much.
Thank you.